So good morning. I, Chair Shelley Bailey, call the Oregon Prescription Drug Affordability Board meeting on December 17th, 2025 to order at approximately 8:01 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman has a power outage. John Murray.
Present.
We have a quorum.
Thank you, Melissa. I want to welcome everyone to today's meeting. We also have America's Sign Language interpreters here with us today. Melissa will soon share information related to how to access the interpretation services, and please use the Zoom controls to access the interpretation channel. Okay, we're now moving to the conflict of interest declaration and meetings with entities or individuals related to board activities. So our agenda begins with the conflict of interest declaration, which are stated at the beginning of each month's board meeting according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And/or have board members provided testimony to the Oregon legislature related to prescription drugs? And with that said, Mr. Murray, I see your hand is raised and you have the floor.
Thank you, Chair Bailey. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs, Inc., comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Thank you.
Mr. Murray, thank you for your time. We are now moving forward to the approval of the 11/19/2025 minutes by general consensus. I would like to ask board members if anyone has any corrections to the draft minutes from the November 19th, 2025 meeting. With me not seeing any hands raised related to that, if there are no corrections, then the minutes are approved as presented. I would now like to call on Sarah Young, PDAB Executive Director, to provide us with a program update. Sarah, welcome, and you have the floor.
Thank you, Chair Bailey, and good morning, members of the board. I hope everyone is doing okay with last night's storm. There were certainly, I saw downed branches and trees on my way in, and you may have as well. As announced at the November board meeting, we currently have a vacancy on the Prescription Drug Affordability Board. We are working internally to post a call for applications to fill that vacancy very soon. Please watch for updates and help us share the opportunity. It will be the same application process through the Oregon State Workday system that PDAB has used for previous vacancies. So I just want to make people aware that that is coming up. Looking back in November and December, the PDAB team has focused on finalizing edits to the PDAB annual report, which the board is reviewing for today's meeting. The team has been working on developing the preliminary drug lists for the 2026 review cycle. We will present the draft preliminary lists for board feedback at today's meeting. And as a reminder, the way we format this is we have separate lists for insulins and for all other drugs, because we are drawing on 2 different data sources for that. And then we made some additional updates to the drug review rubric and a few corrections to the 2025 drug review packets. Over the past month, the drug price transparency team has been focusing on finalizing and publishing the annual reports, which is posted in the annual reports section of the Drug Price Transparency website. It contains a lot of great information, and I encourage people interested in these topics to go check out that report as well. And the team was preparing and presenting for the DPT program annual legislative hearing, which we held on December 4th. The program staff presented a great summary of the information DPT has compiled from reporting by manufacturers, PBMs, and insurers over the past year. And the hearing also heard testimony and informational updates from national experts with varied perspectives on the topics of biosimilars for complex biologic drugs and financing approaches for new treatments that have very high costs, both as one-time treatments and medications that have high costs across the healthcare system due to high rates of use. The hearing also heard public testimony from 6 people and received written testimony from 4 groups, which is again posted on the website. And I encourage folks who are interested in learning more to visit the DPT website and check out those records. I also want to extend a big thank you to our legislative moderators, Senator Deb Patterson, Representative Emerson Levy, and Representative Rob Nose, and also to DCBS Insurance Commissioner T.K. Keene, who facilitated the hearing. As a few administrative updates, I want to give the board and the public a heads up that we are working on a website revamp and will be moving many of the older materials to a new board archive section of the website. Our goal is for all of the currently available public information on the website to remain available, but you will find older documents in a new section. These changes will make it easier for users to find new materials and also ensure that we are meeting new, stricter electronic document accessibility standards across the PDAB website that support the federal ADA accessibility website governance rules. And if anyone, as always, if anyone has difficulty finding public documents on our website, please reach out to our email inbox and we would be happy to help you find the right location. Also, as a reminder to everyone, following the Oregon PDAB process for 2025, we are finalizing our affordability review reports and early next spring and aim to have that report published in March. Next year in 2026, we expect to finalize both the annual report and the drug review report by December. Also, as part of our 2026 work, the Oregon PDAB will be launching an outreach project this spring. We will host 4 in-person community meetings in Salem, Redmond, Portland, and Beaverton in May. And we will also host 3 online meetings, including one with Spanish interpretation. We will also have extended public comment period at the May board meeting. And our goal with this really is to seek input from Oregonians, particularly patients that are impacted by the prescription drugs that the board will be selecting in April and reviewing over the summer and fall of 2026. As we did this year, as part of that process, we'll also seek input from consumers through an online survey and other opportunities for input at the community meetings. In January, we will be posting the dates, times, and locations of the community forums and the online meetings on the website. And as folks know, these drug reviews are complicated topics, and we really want to make sure that we have multiple ways for interested Oregonians to engage with staff and the PDAB's work. So board members and meeting attendees today, we will really appreciate your help in spreading the word about these outreach sessions this spring. And in particular, we appreciate efforts to reach patients and providers who are using the drugs that the board ends up selecting for the final subset list in 2026. Of course, the board has not selected that list yet, but I'm giving everyone a heads up about the communication that we'll need your help with in the spring. And with that, Chair Bailey, I will turn it back to you. Thank you for the time.
Thank you, Sarah. We are now moving to the public comment period of our board meeting. And I want to reference that the public comment period is for general public comments. The board receives 7 written comments, which are posted on the board's website. I'm going to take a moment to read those who those letters came from, just to recognize the letters here for the record. One letter from Dr. Harry Galanter from Let My Doctor Decide Action Network. One from Seth Grenier from the National Multiple Sclerosis Society. One from Anne Murray with Bristol Myers Squibb. One from Jessica McBride from the Oregon Coalition for Affordable Prescriptions. One from Rainier Simmons with the Community Access National Network. One from Tiffany Westrick Roberson with the Each Pick Coalition. And one from Sarah Hoffman from the Partnership to Advance Cardiovascular Health. The board also received 4 requests to speak. I will call on the individuals who have signed up to speak and ask them to state their name and organization. Each individual will have 3 minutes to speak. The board will not deliberate on issues or requests during this time. And Melissa, for the record, before we move forward, I just want to confirm I have four individuals set up to speak. Is that accurate still?
Yes, it is, Chair Bailey. However, I wanted to let you know, Lauren Sant emailed that she lost power and she may not be able to make it today.
Okay, we'll call on her when she appears on my sheet and we'll just see if she is available. So thank you for that update. So the first individual on my notes here today is Daria McGrew from Pharma. Daria, if you are here, welcome, and you have the floor and you have 3 minutes.
Good morning, Chair Bailey, members of the committee, confirming you can hear me.
We can hear you.
Great, thank you. Good morning, Daria McGrew on behalf of Pharma. Thank you for your time today. Today I wanted to speak in support of several of the policy recommendations that the board decided on and is recommending in the final annual report. Oregon has taken the first steps important in PBM transparency, but there is more that could be done. For example, looking at the increasing role of administrative fees and third-party administrators. PBMs are shifting away from making money mainly through keeping rebates. Instead, they are earning more from spread pricing and service fees charged to drug makers, insurers, and pharmacies. These fees have become the fastest growing source of PBM profits. Surpassing income derived from rebates. This can be seen in Oregon's 2025 PBM report data that shows that found that PBMs in this state retained 7.7 million in rebate revenue from manufacturers, but also 33.9 million in administrative fees from carriers and 11.9 million from spread pricing, pay-per-performance, or similar arrangements. Additionally, PBMs and insurers could give patients easy to understand real-time information about their costs, coverage rules, and how to request exceptions and appeals. This type of transparency would help patients make informed choices. In addition, stopping mid-year changes to drug lists would make coverage more predictable and consistent and transparent for patients. Second, requiring rebates to be passed on at the pharmacy counter. Although rebates, as I said, are becoming a smaller portion of revenue, they are still quite significant. Drug makers give billions of dollars in discounts and rebates that are not always seen directly by patients. For example, Oregon's latest PBM report shows that carriers received $369 million in rebates, but shared only $400,000 or 0.1% directly with patients at the counter. So Pharma supports the proposal to pass rebates directly to patients, helping lower out-of-pocket costs and improve access to medication. And finally, Pharma supports the board's proposal to seek an exemption under public meeting law for having media present at executive sessions so that the board can review trade secret information in private. As discussed in our prior comments, the board needs a pathway to appropriately follow both the public meeting laws and be able to view, discuss, and protect voluntary, proprietary, confidential information shared by manufacturers. We will be sharing this in writing with additional comments at a later date after this meeting, but thank you for your time today and your work. Appreciate it.
Thank you, Ms. McGrew. Next individual on my list here today is Jessica McBride from the Oregon Coalition for Affordable Prescriptions. Jessica, if you're here this morning, welcome. You have the floor and you have 3 minutes.
Hello, good morning, board, and thank you for the opportunity to comment today. For the record, my name is Jessica McBride, and I'm here on behalf of the Oregon Coalition for Affordable Prescriptions, or OCAP. Since 2017, OCAP has worked to increase price transparency and accountability to lower prescription drug costs for Oregon consumers. Earlier this month, the DFR hosted the annual drug price transparency hearing and presented their findings on drug pricing trends in Oregon and heard from consumers. I'd like to share a few of the stories. One Oregonian shared that their dry eye medication cost $250 for a 1-month supply with their Medicare plan, and that they are reusing the vials despite the package warning against so that their prescription will last longer. Another patient wrote that they would regularly drive to Canada to pick up a medication that cost $7.50 there because even with insurance, the costs in Oregon was $113.85. The last example that I'll share is an Oregonian who wrote just 2 sentences. The cost of my medication will be a choice. Purchase medication that is needed or pay rent. No one should ever have to make that choice. So today, as you are asking, affordable for whom? It should be Oregonians like these. Prescription drugs should be affordable for seniors and other folks who are living on fixed income. For every cashier who is earning minimum wage. For students who are working to finish school. And for every Oregonian that relies on specialized medication. Over the past year, you have worked to determine more information about the true costs of 16 prescription medications and 7 insulin products. Now you have the opportunity to challenge some excessive drug prices. Drug prices that since 1980 have increased 97.7% more than the rate of inflation for all other goods and services combined, as we learned at the Drug Price Transparency hearing. Right now, there are Oregonians across our state who cannot access needed medication, not because of availability, but because it is cost prohibitive. Every Oregonian deserves to be able to afford the medications they need to live healthy and productive lives. As our state continues to feel the impacts of federal funding cuts, skyrocketing premiums, and rising drug costs, we urge each of you to bring forward your recommendations without hesitation and to remain focused on your core charge as you make decisions as a board. Thank you.
Thank you for being here today. Rainier Simmons from the Community Access National Network. Rainier, if you're here, good morning and welcome, and you have the floor and you have 3 minutes.
Good morning. Just want to verify you can hear me okay?
We can hear you. Thank you.
Good morning. Hi, my name is Rainier Simons. I'm speaking on behalf of CAN Community Access National Network with just a few brief comments today. Firstly, we'd like to express our support for the policy recommendations that were voted forward to be included in the annual legislative report. The policies are more patient-centered, which can improve affordability and access, and can also translate into improvement of system concerns. Most importantly, the policy recommendations are ones that are evidence-based with the likelihood of positive outcomes and are actionable in the more immediate future without strong potential for harm. Additionally, policy recommendations such as PBM reform have already been passed in states like Illinois, for example. And by not including recommendation for the implementation of a payment limit authority, it sends a message to the legislature of the direction in which efforts should be made, which is the patient experience. It also improves the confidence of the public trust of the board because it is consistent with the board's renewed and evolving focus on non-UPL initiatives. In regards to the draft 2026 preliminary drug list, we're concerned that multiple medications used for the treatment and prevention of HIV are listed. Extensive board discussions in the past resulted in not including HIV medications in cost reviews for questions of affordability due to their public health benefit status and proven status of not posing affordability challenges for most patients. Also, to date, all other state PDABs have removed consideration of antiviral medications for affordability review or imposition of an upper payment limit after affordability review because of the unique nature of HIV as a health condition and because of the robust public health programs ensuring both fiscal responsibility of program entities and patient access and affordability. We encourage you to remove HIV antiretroviral medications from the 2026 preliminary review list as well. We thank you for all of your hard work and thoughtful deliberation this year. Your transparent and candid dealings with all the challenges you work through show that at the end of the day, you definitely want to do the right thing. Thank you for your time today.
Thank you for being here today. Melissa, I did just want to check and give the opportunity to Lauren Sant from the Caring Ambassadors Program. If Lauren is here today, I do want to provide her the time to have the floor.
Lauren has not yet arrived. But I'll let you know if that status changes.
Okay, please do. Thank you. We are now moving forward onto our board discussion and vote on the annual report. So each year the board prepares an annual report for the Oregon legislature per ORS 646A.696. Today, the board will vote on the final version of the annual report. The report is included in today's agenda materials, and Courtney Whitlock, Senior Policy Analyst, will help us begin this discussion. So Courtney, you have the floor.
Thank you, Chair Bailey. And Melissa, I just wanted to recognize that Chris has just joined. So if you can please give him the
Yeah.
proper.
Yes, I have changed Chris's settings. Thank you.
Perfect.
Thanks,
Thank
Courtney.
you.
Sorry I was late.
No worries. Hope everything's well. Good morning, board, and thank you for the time to review the material packets before the board meeting. I just wanted to start off with saying congratulations. We've made it through another year and another successful report. We have created the final report. So we're going to go through, I highlighted basically where some additional differences have been from the draft report. And then at the end, you can just vote as is, unless there's any significant conversation to make any small edits. We can do that, but hopefully this report is solid and we can just do the standard vote. So starting off, we have the acknowledgement of everybody, of all the participation, getting the report developed, the TOC, a sheet of abbreviations, since there's quite a few throughout the report. Starting off with the first edit, we highlighted Dr. Hartung's placement to vice chairperson with the resignation of Amy Burns last month. That was just a brief update. This was the additional added language for clarification after last month's conversation, just to shore up the intention of what the trend, price trends indicate, and any just to support additional meaningful information. Again, just light edits that we did. I'll give you a minute to review. Please let me know if you need me to blow up the screen a little bit more for sight. But it is all in the report. And I'm seeing a few head shakes that everything kind of looks good. So seeing no concerns with the edits, I'm going to move on. That was the primary edit section, was the introduction to the price trending. There were some other additional edits that are down towards the bottom. Again, just some highlighted information for clarity of the intention of graphs and tables. And then the biggest addition to the report is coming up, or the recommendations were added into the report. This was one that was also just added to ensure the understanding of the reporting insurers and the covered markets, for clarification of what all that indicates. So I'll give the board a minute to review the updates. Just indicating, oh, Chair Bailey, I see your hand up.
Thank you. While I wasn't crosswalking this exactly against our last meeting, just because I assumed everything that we talked about was reflected in here, didn't we vote on the recommendation related to executive session? Wasn't that one of our items we voted on, to make a recommendation to not have media present? I know that's, I thought that was, I can't suggest that maybe the policy recommendation is the place for that, but I wanted to make sure this document reflects that.
Yeah, I'm getting down to the recommendations. Is it not?
Oh, I'm looking at the recommendation page and don't see it, but sorry, I was looking at page 30. So I'll wait till we get to page 30.
Okay.
Sorry.
Yeah. Give me just a second. I just want to make sure that the board members
I didn't
understand
mean
the
to, I
additional
didn't,
edits.
yeah.
Okay. Well, seeing no concerns with this update regarding the number of reported insurers and covered markets. Again, just additional small edits for clarification of how the top 25 list impacts the trend reports. And then I will go back up into the minutes, Chair Bailey. Let's see.
I can
Is
also.
it not 5B, Chair Bailey?
Yes, it is 5B.
Yes.
There we go. Thank you very much.
Thank you, Chris. Appreciate that. Yeah, so this and then short of the appendix that just include the therapeutic classes that were reviewed and then the drugs that were associated under that therapeutic class. So that is the report, board. If there's no concerns with the edits that were included from last board meeting, and there's no intention for changes, or I should ask, is there any changes needed at this time or any recommendations? Otherwise, I'll have Melissa call the vote. All right, I guess hearing no feedback or concern.
Michelle has her hand raised.
Oh, sorry, Michelle.
Yeah, Courtney, on page 30 in the recommendations under number 2, pharmacy network access, should there be a verb in 2B? Are we saying implement an exemption?
Well, let's go back up to see what the language was. I guess Melissa didn't put in the exact language. A permanent corporate activity tax exemption for. Apologies for the quick scrolling. Well, this matches the language that was voted on, but if the board feels another form description for this is necessary, we can make a quick edit of it, and then the board will just vote on what that needs to be.
Could just be request.
I'm sorry, what was that?
I'm okay either way. I do think the language is probably in alignment with some of the other recommendations we've made, but I think either way probably helps convey the recommendation.
So is the intention to add some clarifying words or just leave it?
I think what I'm hearing is it would be nice to have like establish or evaluate or some sort of what we're asking for with relation to the corporate activity tax. I don't know. I wasn't part of the conversation last month, but
yeah, it could just be request a permanent corporate.
Chris, your hand is raised.
Yeah, Chair Bailey, I had a question that I asked during my check-in with the staff about recommendation 5A, and it is pretty broad. It says expand PDAB's authority to allow for a broader review of Oregon's prescription drug delivery system. And so I just, for my own knowledge, wanted to get a clear understanding of what that expanded authority is. Were there specific things that we wanted to look at? I mean, that's a pretty broad expand PDAB's authority. So I didn't know, and I'm sorry I was not able to watch the conversation from the last meeting yet, but if I could just get a little bit of information about that discussion that happened last time so I have a better understanding of what we're asking for there.
Yeah, I'm happy to take the first pass and for anyone to fill in any gaps or a different perspective than the one that I had. But Mr. Murray, your hand is raised. So did you want to?
No, you start
okay.
Chair Bailey. That's
okay. No, I think Chris, at least from my perspective, the intention was to we have these more specific recommendations, right? But then we had this broad recommendations so that it would really be up to legislators to kind of review what's provided in the annual report, review what we have in our more detailed recommendations, and then have this broader recommendations so that legislators would be able to, learn from the advisory role of this board and then be able to take what we've kind of educated it with and see what they may want to do with, with PDAB, because we do have very detailed things in some pieces of the report. So I think we wanted that flexibility so that legislators could see that it could be all of these things, some of these things, broad. But I think we wanted to just be able to enable legislators to have some flexibility. But Mr. Murray, your hand is raised, and obviously welcome every other board member's perspective on that discussion.
Thank you, Chair Bailey. Chris, my intention in the discussion at last month's meeting was just kind of a reminder that the PDAB is only an advisory board to the legislators, and my hope was that we could expand the authority of the PDAB to bring information to the legislators, and that's it. Yes, we might make recommendations after study, but really to bring, for example, experiences from other states. We don't have to reinvent the wheel, I don't believe. But if we don't ever hear about the wheel, it's really hard to make improvements. And so I'm not suggesting that there's a particular agenda. I just want to open up the conversation, allow the PDAB to open the conversation amongst all the players. And like I said at the meeting, I would love to have someone from the plans in Oregon explain why spread pricing is needed to pay their PBM bill, for example. Those kind of conversations need to happen. And the more we hide things, more we don't discuss things, the worse Oregon's going to fall further behind. I don't want to be twice as bad access for pharmacies as the rest of the states in the nation. So we've got to do something. What we're doing in Oregon isn't working. Let's at least talk about some other ideas, please.
And I guess following that, Chris, did that kind of clarify your question
Yeah,
about it? Or do you feel like...
I guess I would ask John, do we need an expansion of power or authority to have those discussions? I think maybe we could have some more focused discussions on that during the course of the year. I mean, we make these recommendations at the end of the year. Is there specific authority that we need to be given by the legislature in order to have those meetings or discussions? I'm not disagreeing with anything that you just said. I'm just trying to understand what authority are we asking for?
My take on it is that there are those that believe we do not have the authority to bring up certain topics.
Okay.
And that's my concern. I don't want to always have that hanging over our head. If we're just bringing ideas forward, we're not voting. We don't have the right to vote in these policies. We're only bringing information forward. Why should there be a restriction on us? Why should we have the ability for others to discredit our work by simply saying, well, that's just not their responsibility or that's not their purview? So that was my request. And I don't know what guardrails or why we would need guardrails on the topics that we bring forward if it's purely for informational purposes. So
okay, I think for me, the only thing I would say is I think we've struggled to get through what we are tasked with. I mean, I don't think that we've been able to complete the reviews without having to ask for an extension. And so to add other discussions about things other states are doing or other options to reduce prescription drug costs in the state, it would add time certainly to what is asked of the board to be able to do all of that work and complete the reviews that were, why the board was formed to do. So
well, I do think one thing related to flexibility is because we will in 2026 be choosing up to 9 drugs. I think later in this meeting, we're going to have some preliminary discussions about next year, but we will have the opportunity to basically envision how we're doing things a little bit different because we don't have the prescriptive target number of drugs, right? We have this up to 9. So I think at least my perspective in the previous discussions where we voted in November was that we will clearly be doing what is identified in statute for us to do, but because now we have up to 9, we also will be able to, enhance some of the discussions that we're having and provide us with more bandwidth to do it. And I think the intention was just for legislators to be aware that there are individuals on the board who do feel that there are additional things beyond the existing statute that could be helpful to Oregonians.
And is that clear in this wording? Like, so if you're a legislator and you're trying to do what PDAB is recommending and what John just explained, which I agree with, is that going to be clear to them in the way this is worded? Because when I read this, not being part of the conversation, I didn't know what expanded authority was.
Yeah, I hear what you're saying. From my perspective, again, I was biased because I was in the meeting, but I think we had very detailed, descriptive, very, specific, many of these item numbers are very specific. But then, and I like how that was number 5, essentially, because at least from my lens, you're kind of reading it. If I'm a legislator, I'm kind of learning from the report. I'm reading the recommendations. And then when I get to number 5, which is the last of the recommendations, it's like, okay, there would have to be changes in number 5 to also help support some of the other numbers. So I think that was at least from my perspective, the intention of kind of how that dialogue went. For example, I think if number 5 had been number 1, I think without the context of 1 through 4, it might not have led to that thought process, at least the way I see it.
Okay, thank you for the conversation and the explanation.
Yeah, absolutely. You could not control weather or having power, right?
All right. Well, thank you, Chris, for bringing that up and just, ensuring that the recommendation is going to meet the intent for legislators to be able to do something for it. And the hope is that, like Chair Bailey was just saying, there's a lot of information in that trend report that if legislators feel it's at the board's capacity to help extend some of that preview of information. And I guess any other comments or suggestions or conversation that needs to occur before we provide the vote, short of just this small added word?
Lori, I see
Lori, yeah, see your hand up, Lori.
I actually wanted to bring this up before this lengthy conversation. The action verb request, I think, is a little weak, and I think recommend might be a better action verb because it has a little more emphasis.
Yeah, I would agree. Yeah.
Okay, even though it's already under the recommendation section, that's everything in here is a recommendation. So, I mean, that's again, recommend to recommend.
Consistency.
All right, well, again, this is your recommendations to the legislators. So if that's the word that the board feels is best suited, we can go with that. Michelle,
yeah, go ahead, Michelle.
I was just going to say we could be consistent in number 2 and just say adopt, similar to 2A.
I see Dr. Hartung's thumb up for that.
I think it's clear what we're asking for, but I think adding adopt is fine as well.
Okay, perfect.
Courtney, while you're making that just semantic change on this, I do want to state that for the entire team at Oregon PDAB, this is by far the best work product for an annual report. I really like how you guys provided the information, then gave the background and then also referenced the how and the process and the recommendations. So whoever was in charge of structuring it that way, I thought it read really well. So it was easy to follow. But Mr. Murray, your hand is raised.
I was also going to thank staff for the work on this report and the quality of it, and also the review process, and kind of tying back to what Chris was saying about our capacity to handle additional tasks in 2026, should it be allowed that we can expand our capabilities. I was pleased as we worked through 2025 and got to this point with our drug review process. And I'm hopeful that 2026 will use what we've learned up to this point, and it will be a much smoother, we won't have those bumps in the road or those delays that we might have had in 2025 or late 2024 even. So I'm hopeful that we'll have the capacity to add additional tasks should we be granted that.
Thank you, John. Sarah?
And I wanted to thank the board members for their kind words for the staff's work. It was really a team effort, and particularly Heather figuring out ways we could use the newer and higher quality DPT data, and Courtney really working through how to structure and communicate that information in this annual report. So I'm really glad that you feel it's a high quality product. And I would also encourage the board members, as you're reading this report, please be thinking ahead to next year, and what we should do differently. As we saw in the questions and conversation about the data presentation at the November meeting, the ways that we get especially insurer data from the Drug Price Transparency Program are kind of complex. And it's that we have these sort of moving targets with different drugs becoming part of the top 25 list for different insurers and different market segments. So really appreciate your kind words. Also appreciate your feedback on things that are confusing. Were confusing this year and that we should do differently for next year, so that we can continue to iterate and make this report both meet your needs and clearly communicate to Oregonians the work the board is doing. So I just want to plant that seed as we're finishing this report and thinking about preparing for next year's.
Thank you, Sarah. So if I don't hear any additional modifications, would it be appropriate then, Courtney, for Melissa to call a vote?
It is that time. Thank you, board. I appreciate all your help and assistance with this year's annual report.
Thank you again. And Melissa, you have the floor, and if you could please help us vote on this annual report.
Do we need to
Yes.
make an official motion, Chair Bailey? I don't know how
Of
that.
course we do. Of
Yeah.
course we do, Mr. Lehman. Thank you. Do we have a motion to vote?
I'm happy to read that motion, Chair Bailey.
Thank you.
So motion for annual report to approve the 2025 annual report as amended by the board today and delivered to the Oregon Legislature by December 31st, 2025 as required in ORS 646A.696.
John will second that motion.
I'll call the roll. Lori Hoagland,
Yes.
Dan Kennedy,
Yes.
Michelle Coder,
Yes.
Chris Lehman,
Yes.
John Murray,
Yes.
Vice Chair Dan Hartung,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes.
Thank you. And I do now want to move back to the general public comment period. We had advance notice due to weather that Lauren Sant did not have power to be able to participate, but I have been made aware that she is present at this time. So Melissa, if you could please put the clock on the screen for everyone's benefit, and then also acknowledge if Ms. Sant is here. Welcome, you have the floor and you have 3 minutes.
Okay, and Chair Bailey, I'm searching again for Lauren. Lauren, if you're here, could you raise your hand? I believe Lauren may no longer be in the meeting.
I appreciate the additional information, Melissa, and we will move forward with the next portion of the agenda. So today, the staff will present to the board draft preliminary lists of prescription drugs and insulin products for the 2026 review based on commercial insurer reporting from the calendar year of 2024. These lists are being shared at this stage to obtain feedback and ensure information aligns with what the board wants to use when the official review begins in January. The draft lists are posted on the Oregon PDAB website with links included in today's agenda materials. Courtney will now lead us in this discussion.
All right, thank you, Chair Bailey. I'm gonna go ahead and share my screen.
While you're doing that, I'll also announce we will take a break around approximately 10:30 a.m. Pacific.
Yes, thanks, Chair Bailey. So board, I mentioned earlier, my apologies for the last minute slide deck addition. I did email you this morning the deck, and we will post it into the material packet after the meeting today. So I just felt a slide deck would probably be a little more appropriate to help guide the conversation and for our board to, or for staff to be able to get the necessary information that we're looking for and to level set kind of the changes from the 2025 drug selection and into the 2026 selection. So in the material packet, this hopefully looks familiar, is the flow chart that was kind of developed and how the 2026 preliminary list was developed. We were DPT, commercial insurer reporting, received close to 5,000 rows of data. And what this included was the top 25 most costly, top 25 most prescribed, and the 25 with the greatest increase for each segment market, which is the individual, small group, and large group. And that included the categories associated with generic, brand, and specialty drugs. And so all the following filings are based on claims from the calendar year 2024. So again, apologies that we have like a 2-year gap in review of data, but it is part of the necessity for how the DPT reporting comes in. And then this was aggregated across 11 insurers and reported to the Drug Price Transparency Program. The aggregated files are applied based off of a summarized proprietary name, which kind of consolidates the drug names by the insurers of the medication. And then basically the prescription drug or the naming convention is based off of the claims, enrollee count, and spending. And all that was deduplicated in the insurer reports so that the same drug, for the same drugs that came across multiple lists. And then the DPT aggregated that data, distinguished between the brand and generic drugs, which I'll show you just shortly, and using Medispand, that's how the brand names are identified. So basically through all that process, 650 products were identified. And I'm going to go on to my next slide. So the aggregated files, then we had to look at how to get from that 600 down to a reasonable data amount. So last year's reporting, board members made the recommendation to cut insurers off at 6. We decided to go with 5. So reporters that had 5 or more carriers, so basically it's 4 or fewer carriers removed. And what this did was that the 4 or fewer provided more accuracy in removing any plan-specific outliers. It improved the comparability across all the carriers and ensured the analysis reflected drugs with this across system-wide. And so we're going to be looking at 5 or more carriers. And then again, I'll mention when we start looking at some other, how last year's subset list was developed, the board did remove 6 or fewer carriers. But for now, for this conversation, the removal of 4 or fewer, so we're removing 5 or more, it resulted in 137 drug products on the current preliminary list for the upcoming 2026 review. The file, oh yeah, sorry, Dr.
Just quick question. The DPT data, these are net costs?
They are net cost, yes.
Okay.
In the spreadsheet that is posted online, we are still working with our clinician and collecting information through the FDA and Medi-Span and CMS. And the spreadsheet I'll be showing you is expanded with those rows just for conversation for today. And then once we have that those data points input into the spreadsheet, we will post the spreadsheet for update and have it as the primary preliminary report starting for next month's conversation. So with that, I wanted to come back to to remind the board what the 2025 preliminary list drill down was following that our Rule 10. So last year we started off with 158 drugs. And to get to the subset list, the board did decide to remove 62 orphan designations. They removed 25 generic drugs and then removed vaccines, toxoids, and diagnostic products. Also removed any drugs that had generics associated with them, and then filtered out drugs with less than 6 carriers, which I had just mentioned that staff had already removed 4 or fewer. And then 27 drugs remained on the list for the review. After that subset list was sent to the carriers, back to the carriers for the data call, the additional analysis, once we got back, identified that we had a few more orphan drugs on the list, so those were removed. And then at that time, we had the APAC information associated, so the board selected drugs that had 500 or fewer enrollees, and then that led us to the current 16 drugs identified to be reviewed. So that's what the process was, where the process has been to set up the current list. And now I just want to touch base on kind of what the differences are between last year's list and this year's list. And we'll the next slide, it will be kind of the naming conventions that are important that I really want to get the board's feedback on. So with this new 2026 preliminary list, there's the summarized proprietary name is, in my list I'll show you, is the FDA proprietary name and the FDA non-proprietary name. For the startup of this preliminary list, for summarization of the drugs, majority of the drugs were provided as a summarized proprietary name, usually just one word. Included in this report, we wanted to show you kind of the challenges that staff has with the DPT carrier reporting, because carriers report multiple names for their non-proprietary. And so we will be probably removing that, but it's just for showing of kind of the challenges that we have for initially setting up and why sometimes this data can be a struggle for aligning what the proprietary drug name should be. We have the year-over-year increase, kind of doing some differences with the orphan designations this year. We have identified, what we did as we went through, identified if the drug is orphan designation, and then included the designated condition and then the number of orphan designated conditions to kind of help facilitate what orphan drugs, what their designated products are. And then we have the maximum fair price effective year. Last year, we just said if it was a yes, no, if it was on the list. This year, we're going to include what year it becomes effective. Things that have been removed that were on the 2025 is therapeutic equivalents and biosimilars. I will explain that more in detail. We are expanding that category a little bit. drug that has a therapeutic alternative, and then drugs on the 2020 or the manufacturer reporting. Just because DPT hasn't received any manufacturer reporting due to the lawsuit, and then the drugs on the CCO list. The board did not review any information associated with the CCO list due to that it was very close to the APAC information. So we're not going to collect any information from CCOs as it's already kind of reflective in this APAC information. So before I move on, is there any questions kind of about what the new columns are versus the ones that were removed? And I will show you the spreadsheet in just a moment so that you can kind of see what that looks like. But if I'm not hearing anything, then I'm going to move on.
And Courtney, I just wanted to lean into the bullet related to orphan designation. Is that to suggest that when we do receive the data call, we believe this year we will be able to data mine for the claims that may have an orphan designation and those that would not? Like, is that so that we can,
yeah, I think let me get to the spreadsheet. And so maybe that visualization will help kind of facilitate the conversation. But thanks for flagging that question. So again, there's some naming conventions that are kind of different from the 2025 to 2026. Some of it is just for clarity of product or where the information is coming from. Therapy class versus therapeutic class. The proprietary names are based off of FDA proprietary names and non-proprietary names. We decided to go with the sum of RX and happy to put it back to number of prescriptions because it is based off of the sum of the claims reported from DPT and then the sum of enrollees. There's some differences regarding the total annual net of rebate spend versus the total annual plan spending allowed for the dollar amounts. I do believe it's important to make sure that we are capturing what the board wants as far as the language. So we're happy to change these back. This information was pulled over from the drug price transparency reporting. So as we set up for the next review, if the board wants these columns to go back because these were edited last year, and these ones that were in the 2026 were just pulled over from DPT. Shelley, I see your hands up.
Okay, so just if I'm hearing you right, you're suggesting that the 2026 column names are in alignment with the same name that is used for the DPT data call. Is that?
It's not the data call. So okay, DPT reporting.
Sorry. Yeah, not the data call. Sorry. So so then the next question would be, okay, so were those fields standard names for reporting from carriers, or did DPT decide on those names?
These are the standard reporting fields.
Those are the standard reporting fields. Okay. Because some of those names are a little not as much in alignment with what I'm used to. So that's why I was asking. But Mr. Murray, your hand is raised. You have the floor.
I was just going to comment. The last three will be confusing to me if they change. I prefer the 2025 column names.
Yeah.
They're more descriptive to me. I'll go with whatever the majority of them want.
Yeah. All right. Sounds good. Dr. Hartung.
So the data are the same, you're just saying the names are going to change?
Yeah, the column titles.
Okay.
And so then how that information is applied, whether it's in the dashboard and the reports and those kind of things. So
yeah, I mean, so total annual plan spending allowed dollar amount is very confusing, and it just I would just use the old whatever you used before, total annual net spend.
Sounds good. We can do
Yeah.
that. And Chris, I see your hand up.
I was just going to say the same thing, Courtney.
Okay.
Yeah.
Perfect. Well, then I will just highlight those to remain the same. I appreciate that feedback. We will make those corrections before we publish the actual preliminary list. Chair Bailey, I see your hand up.
So I could go how the wind blows on this with everyone else, but I mean, from my perspective, the whole bottom five seem, but with that said, I don't want to make any potential for more challenges for staff if we're not using the same column names as DPT. I don't want anyone that's looking at this information externally to also, there are other stakeholders or constituents that are reviewing it to be confused. So that would be one reason why, while I don't like the last 5 personally, maybe we should keep them in alignment with DPT.
It really isn't for the staff's benefit. This is strictly for the board's benefit for your review. So I think majority kind of say stick with the primarily the bottom 3, but I'm so happy to keep the naming conventions for the number of prescriptions and the number of enrollees versus some. So Vice Chair Dr. Hartung.
I mean, just for clarity, you know, the question always arises whenever we talk about money spending. It's like, is it net or gross? So making sure that that's in there in the title, just so we don't have to like, is that net? I think it's important. But other than that, just, you know, just clear, concise names. You know, annual spending per enrollee is pretty clear, but annual net spending per enrollee is better. Annual net spending per RX is better. So just descriptive, concise, I think is the key.
Do you want an RX or prescription? It doesn't matter.
Doesn't matter to me.
Okay. We'll keep it a prescription. If we have a crosswalk, if we need to abbreviate it in a footnote for like in the report, sometimes it's easier for us to shrink those down to fit in the columns, but we'll go there. Dan Kennedy, I saw your hand up.
Yes, I'm just in agreement with the group that the bottom 3, I think, are more concise on the left-hand side than the right-hand side. And I think the right-hand side would just beg the question, is that net or is that gross or is that total mean net? So yeah, I'm with the group on this.
Perfect. And just for clarification, does it make a difference to board members if it's number or sum of enrollees or claims or anything like that? Michelle?
For me, the difference between number of prescriptions and the sum of claims is an important thing to distinguish between, because you could have multiple claims to fulfill one prescription. Particularly if you're short filling something. So, and that is, you know, if they're submitting claim level data, I think that's an important distinguishing factor.
Okay. Well, then I think it would probably be best if we just maintain those as they are. So work for everyone? All right, seeing heads nodding, thank you very much. I'm going to go into the next slide, kind of the same. Same thing. So number of carriers versus the sum of insurers. In the drug price transparency, or sorry, not in the trends report, in the annual report, the name that was used was insurers, not carriers. So just for fluidity of what is going to be published to legislators, trying to maintain that same terminology. So looking more to align with insurers versus carriers in the next review as much as possible. Again, these are just updated names because some of the columns need to make sense, and I'll show you those in just a moment. I don't think there's really anything else that I really need board feedback on. These are just how we're just updating the spreadsheet so that the added information is more fluent this time around. Chris, I see your hand up.
Is the exclusivity piece, I mean, that's exclusivity expiration year within 18 months.
It will still be in there. It's just named differently.
Okay, so it's not the year like 2027, like it could be January 2027 or December 2027. It's just.
Yeah, when you see the columns, we might come back to that, and then so just hold that thought, and then maybe as we go through the columns, like in the spreadsheet, it will make sense. So, no, but hold on to that. But I'm not seeing anything else. I'm just going to jump into my last little questions for the board. And I might have to flip through these questions to the spreadsheet. So let me pull the spreadsheet up. And are you able to see the spreadsheet on the screen? Sometimes it doesn't always pull over. Okay. So this is what the green is what was in the online reported spreadsheet. And they are the newer ones. The proprietary names, these are the FDA ones. The summarized name again is basically all the same, but like instead of a butyl sulfate, it's just a butyl. So those are kind of the difference for quick analysis, just using that one name summarization with the intention for it to represent the FDA proprietary name. But going first to Shelley's question. So this will be added in, again, we're working to get these numbers. This will all be included in the spreadsheet in January. The orphan designations, we said, again, same thing, yes, no, and not listed from last year, but this year we added in what the condition is. And so like for this drug, amphetamine, I think it was, has a orphan designation for treatment of pediatrics with Tourette syndrome, and it only has one. So the kind of thought process for staff behind this is if we're able to pull out in the data age range, so we know that drugs for pediatrics are easy to remove out, and then board can still have the opportunity to review drugs that may have the designation just for the pediatric, but still review for adults. And I think the best example I have is like Skyrizi, so the board has the opportunity this time to review orphan designations with staff being able to remove at least the age ranges, not so much specific diagnosis because we don't have the diagnosis codes for the claims yet, but we're working on that. Dr. Hartung, I see your hand up.
Yeah, I wanted to just have a larger or broader conversation about this element here. I was re-reviewing our founding legislation and the rules just to clarify in my head exactly what we are and are not allowed to consider for drugs that have an orphan designation. And I was a little bit confused, and I may just miss something in the language. So in Rule 20, it says a prescription drug approved by the FDA for other indications in addition to a rare drug, disease, or condition is not exempt from an affordability review for those other conditions, which I think is getting at what you're talking about, of trying to target, focus on the non-orphan conditions. But I was looking at the actual legislation. Let's see here. Shoot, I thought I had it pulled up, but give me a second here.
Here, I can pull up. So this is our governing legislation.
Search rare. That's where I'll flag it. Yeah, so it says a drug designated by the secretary as a drug for a rare disease or condition is not subject to review under subsection 1 of this section. And there's no other like caveats that I could find in it. And so it led me to think that we just can't review any drug with an orphan designation, regardless if regardless of 95% of its use is for non-orphan conditions. So and I realize in the rules, it gives us this out. And I was just curious how we were able to make that leap. I can't remember.
Yeah. So, and we can always bring this back, and maybe we have to go into executive session to
Which I
maybe have.
recollect is what we had to do
Yeah.
previously.
I know we had
So-
extensive discussions about it, but I can't remember. I don't remember exactly how we went from you can't look at this to you can look at these for their non-orphan, because it seems pretty clear in the law here.
But what they're referring to here, the drug that is designated, is the designation. Like, hold on, I have a lot of screens open, so let me find it. So the drug that has like, so hold on. All right. So a drug that is designated by, so it has a designation, and that is this designation, like the treatment of Tourette's, but we can still review outside. And again, our council and, the 3 years that we've been doing this, we've set the rule up in a way that is legitimate for us to be able to do it. We just never had the process to be able to pull out some of this information. But I'm happy to take it back and talk with the execs and, our legal counsel, DOJ, to ensure that, just to reiterate that this is this process that can absolutely happen, for your clarity, Dr. Hartime. But it is the path that.
Okay, yeah, no, I really want to, I definitely want to do it. And so, but I was just like firming up the foundation of it when I was thinking about it. And so, and if we already established that we're on firm, kind of footing to do so, I'm definitely in favor of it. I just was confused.
Yeah, no, and this is, like I said, it's important for us to be able to set up, the next cycle to be the most meaningful for board review. And again, if you kind of look at the trend reporting, a lot of the drugs that were high cost drugs were orphan designated. So those would also be, kind of a concept to, lean into, being able to kind of look at drugs that the smaller populations can be removed. But Lori, I see your hand up. I want to make sure I get your.
So I guess my question is, do we have access to separating the data for the orphan use versus the other use, in terms of numbers and of claims and numbers of people impacted?
Yeah, so what we'll be able to do primarily is focus on drugs with the pediatric removal, because we have age and we can remove those out. But anything specific to a actual condition, we do not have access into that. So that's why some of these that have the one are primarily focused around the pediatrics, we can pull those out, and then you just have the sum of the adult ones that would be reviewed, and anything that's, the cost only for adults would be in that, because the rest of the information for the pediatrics would be removed.
And I want to add what Courtney is saying there. As Lori is pointing out, this is trying to analyze, and to be clear, this would be from the all payer all claims data, that we could do some of this analysis. It is more complicated and is not something that staff has done before. So it's going to take additional time and work. We're pretty confident that we can separate the claims data for pediatrics from the claims data from adults. We are limited in the diagnostic information that's available on pharmacy claims in APAC. So subcategorizing within age groups by different diagnoses is probably not something we can do right now. I'm aware in theory that people who are really expert at doing claims data analysis can do multiple matching and things sometimes to do more of that. I don't know that we can get that far this year, but we want to do as much as we can with the data we have available to help inform the board's work. So, I do want to maintain reasonable expectations about what it's possible for us to do with the APAC data, because this represents quite a bit of work for staff. At the same time, we want to do as much as we can to support your work.
Chair Bailey, you're up.
Oh, please give the floor to Vice Chair Hartung or Mr. Murray. I just will make a recommendation after we have finalized the discussion.
Okay, Dr. Hartung, I saw your hand up.
Yeah, no, I mean, I support this the general concept that you're talking here about, but I'm wondering in terms of like workload and the complexity of what we're thinking about. If I mean, perhaps we're putting the cart before the horse in terms of, you know, we're dealing with this list of 137, 160 drugs, and you know, trying to, you know, to me, it doesn't make sense to try to parse this out at this level, at this stage, given that, okay, orphan designations are orphan because they're rare conditions or diseases, whatever, you know, 200,000 Americans or whatever. And so, you know, I think we can make some assumptions that if these drugs are in the top 25, you know, not all, I mean, sure, certainly not all of them, but if they're in the top 25 by spending and change in spending and prescribing or whatever, that the most of the use is not going to be for non-orphan conditions. I mean, so at this stage, so, you know, I think moving to the next stage, when we identify the drugs for affordability review, then we can use the detail drill down with APAC to try to like skim off the people who might be using these drugs for orphan rare conditions. But like, this is a lot of work. I recognize that this is a lot of work right at this stage, and I'm not sure that, you know, the juice is worth the squeeze at this point. For several of these domains, like just to get to this list that we moved to. And then when we move to the affordability list, I am in favor of doing more detailed analysis with APAC to really sharpen those reports up. But I just want to be mindful that we have a lot of drugs here, and like, you know, someone's going through and finding all the therapeutic alternatives, find the exclusivity dates. And so this just doesn't seem like the amount of work involved in that at this stage is worth it.
So I appreciate the feedback, but there's some nuances that the board really doesn't see from a data perspective that we need to get ahead of. And one of them is when you get down to identifying the subset list, we have a small amount of time to get that list back to the carriers. And last time we didn't have the therapeutic equivalent or the therapeutic biosims or anything like that. And so we had this gap of information for the subset list. And even though we leaned primarily into the APAC data, we had no net information on those. So for right now, we're working to get the therapeutic and biosims and alternatives so that in the future it doesn't have to go back to a clinician. It really is just we pull the drugs and therapeutics are there, and then we send it over to the subset list once it gets to the data call to the carrier, so we can get all that information meaningfully. I mean, the orphan designation condition and numbering, that's already been done. It's on the list. It's just an identifier for the preliminary list. Anything else associated with that would just be a drill down. But it is important, so if the board did decide on a drug or two that had an orphan designation that might meet the criteria, we already know what the conditions are. So there, and this is, again, just the preliminary list of information to make it as meaningful as possible. So I just want to create that clarity we need some additional information ahead of time associated with the therapeutic equivalence, alternatives, and biosims, so that when we send it to the, once the board selects that subset list, then we can immediately turn it back over to the carriers and not have to wait 2 or 3 weeks to get any additional information before sending to the carriers, because that just adds to that time gap that is really, really precious to us in this fall, or sorry, the springtime, we need to get the analysis put together. But I wanted to spend let John have a moment or answer your questions, John.
Yeah, thank you. I was just going to echo what Dr. Pertine was talking about, and I apologize because Courtney, I didn't understand exactly all of what you just said to me, and the timing of the information gathering. You know, I understand and support continuing to keeping the orphan drugs in the discussion, in the consideration, as long as we have the data to back it up. It's one thing to sift out patients based on age, which we may have that information submitted to us, but how do we submit, or how do we tease out information based on an indication when I'm not sure we have that information? So I guess I'm concerned about how we proceed with that as we go, but maybe I'll see that in the data that's submitted to us. Last year, we removed 62 orphan designated medications right off the bat. That was one of the first things we did. And so it would be nice to keep them in the discussion as long as we have the data to support a wise decision or a good decision.
Yeah, and that's the intent. Sorry, Shirley. And that's the intention, is to improve the reporting process so that we can look at drugs that may have a designation for one particular age group, but again, as it was Sarah said.
And Courtney, I do want to let you know,
we don't have claims data. They're out by age. So basically, if we did this, you know, it'd be, so even if a child didn't have Tourette's, it would just be all age under the 16. And then we just look at adults, those kind of things. But we're still looking at how to get the process completed. We're just adding it into the preliminary list as a point that the potential is to review drugs that are high cost, impacting the system, impacting patient out of pocket, that have had this, you know, orphan designation associated with them that the board hasn't been able to review before. But Chris, I wanted to give you an opportunity to.
No, I think you just said it, Courtney. So like my question was going to be, is there an ask then right now of the board? Because what I think that to John's point, what we did last time was sort of the first step was to filter out all the orphan drugs. But it sounds like we have a way now to, for certain conditions based on this age, filter out the orphan drugs, but keep a subset of the orphan drugs that have a very specific indication that is only for a certain age range, because we know the ages associated with the claims. So you could essentially keep those orphan drugs on the list. Is that right? Going forward to the next.
It's still the drug. It's the orphan designation associated with the drug, right? It's a orphan condition. It's a condition that the drug treats. That will be
totally
removed.
Understand. So we're like, my wording may be a little bit off. So the drug stays on the list. If it has an orphan indication that is so specific, using the data that we have access to, you're able to just basically filter that whole group out and look at everything else, not for that orphan indication. So maybe 5 or 6 of the orphan drugs that we would have had to filter out are now going to be able to stay on the list.
That's correct, sir.
Yeah, I mean, that sounds great.
Okay. Chair Bailey, see your hand up.
Mr. Murray, you go ahead and share your feedback, and I have a recommendation just at the end of this specific discussion. So you have the floor,
John.
Mr. Murray.
Yeah.
My
John, go
apologies. I didn't hear that. Sorry. I apologize in advance for my bluntness. I see. Well, let me ask this question. So orphan designation exclusivity lasts longer. I mean, it stays with the drug for a longer period of time past, for example, patent exclusivity, correct? So then I would say that this, and to my way of thinking, which I'm particularly sensitive to what I call games in the pharmaceutical realm that prolong affordable medications coming on the market, or even looking at them from the PDAB perspective that allow for higher cost drugs to stay in play and negatively affect affordability. And I will address my comments a little bit in our next conversation about affordability review, particularly about patent dates and things and high cost drugs. But exclusivity, if that stays with the drug the entire length it's on the market, and we don't even talk about them because of one indication and they have 10 other indications, I'm in favor of trying to look at the other 9. So.
All right, thanks, John. I appreciate that. Chair Bailey, see your hands up.
Thank you. So a few thoughts to just help us advance, because we do have our 2025 affordability reviews to discuss. So the way I see it, the additional information presented to us today has helped fill in some gaps that we've had challenges related to in the past. We are aware that the program does not receive potentially accurate diagnosis codes for a myriad of reasons. Some pharmacy management systems pre-populate. But it does sound like, as a reminder, as a board, we can, for the next round of reviews, we can restrict the lens of how we want to look things, but what we can't do is expand. And so to me, this is a tool to help us do more than we were potentially able to do in the past. But my main thought here is I really would like to ask that we have an executive session in January, knowing that we do have our vote. If we could have that discussion in executive session, I think this is a critical piece that the board needs to hear from. We need to hear some additional information for, even if just as a refresher. So if we have the time in the agenda for January, I would like to request an executive session.
All right, we will see where that parameter, because we do have very specific.
Yeah, and if
expectations
not
to go in there.
January, then February.
Yeah. And again, this is just the conversation to make sure that the preliminary list for 2026 is being set up in a meaningful way that's going to help board make their decisions. We don't need to make any specific changes or anything like that today, and then we have the rest of the month and into next month to also talk about the setup, as board members can reach out independently to staff. I do want to be mindful of time, but Dan Hartung, go ahead, and then I have a couple questions for the board to help.
Oh, my question was, was there a specific ask that we needed to weigh in on at this point?
Yes, there's a couple of things. So as far as the meaningfulness of some of the dates, so we do not at this time have this section in the 2026, which basically ranks the greatest increase. So this indicates if where the drug came in, but it's already indicated in the list type. We do have the list type. We just did not incorporate the specific draw out of where it landed on the drug. And we did not include at this time the ranking. And if the board felt that the ranking was essential, this is not something the board leaned into last time. It does take some time because it's a kind of a manual lift. So we wanted to make sure that we're still incorporating something that might be meaningful for private reviews, independent reviews of these drugs. If not, then we don't have to incorporate them into this year's list. And I guess if I'm not gonna, Dr. Hartung.
So now that we've been through the whole process and I kind of have a better understanding of the data quality at various points and where we're going, I'm a little bit more, the data quality on the DPT data is, I get what it is, and it's like trying to be so precise with it, I feel like is not the best use of analyst time. And so, and I'm supportive of processes that accelerate our our work through this DPT list to get to the preliminary data as quickly as possible. And so the less we do, the less we have staff do to try to like massage these very deep, complex, detailed data from the insurers at this stage, I think is direction in my opinion we go. And so, you know, even just like, you know, having a list of drugs that are the most costly, the greatest increase, and then the most prescribed, and then rank them by spending. I mean, to me, that's like 70% of the work in terms of then we have that list and we can kind of think through like the exclusions and things like that just to get to the next phase. So it's not a specific recommendation, but it's more of just like a philosophy of like having you guys do less work with this data and get to the affordability reviews and the data call stuff as quickly as possible.
Okay. I can run with that. If no other board members have feedback for us, we can go with what you're saying. Because again, we already have the list here, right? And then we have the annual. No matter what this list may look like, you're still going to have the same annual spend and then the breakdown. So that works for us.
I mean, I'd like to hear other people's thoughts about this because we spent a lot of time on it, and like I felt we were really rushed through the affordability reviews, and like I feel like we all have a better sense of like the work involved.
Yeah. So again, if any other board members have feedback to keep or remove this.
Courtney, really uneducated question here. As a reminder, can you tell me what the GI, MC, MP, and ME stand for? I
So
know
it's
I should know.
greatest increase, most costly, most prescribed, and then this was an added equation for most expensive. But it's not the top 25. It's not. It's just it was an additional equation that was created.
Total, but not part of the 25. Okay.
Yeah. So
and then to Dr. Hartung's point, it is duplicative as a sum on the other. Okay.
Yeah, and so then this is the ranking of it. So, you know, these are all kind of the more top of the list where they came in on certain drugs. So whatever the carrier reported is the greatest increase, most costly, these were the ranking that they came in. And so I don't know what the value is at this point in our doing this a couple times. These really haven't been any derivatives of decision making for the board. It does take a lot of time. It's manual concept. So we just want to make sure that if it was removed, that we're not impinging on anybody's decision making. And then that time can be a lot of doing more meaningful analysis on other points for us. Dr. Hartung, I see your hand up.
Yeah, so I mean, I think we should get rid of them, or we don't need to do them. But like can you go back to that what you're just showing, just so I understand what I'm advocating here. The GI rank, greatest increase rank, like 139. Is that from one carrier? Is that from all the carriers? Is that as like a summary, a aggregation across carriers?
So it is, I believe, the aggregation across the carriers.
Okay.
What that is, and then it totals out here of what the rank is. So again, it's really not used very much. We don't even use it as analysts. It was something that was originally put in there as a kind of concept to see where the drug fell within the reporting structure.
Yeah, so I mean, because we have net spending and right as a data point. So I mean, it seems kind of duplicative. I mean, the one data point that I think is, because these are all dated, you know, this is from 2024,
2023 data.
Oh, okay. So yeah, so the one thing in terms of like spending analyst time on that might be helpful is like generics available, because there's generics available, like generics or biosimilars available now.
Mhm.
Like if those things are out, they emerge on the market in this interim period between when the data were pulled and what's available in the market now.
Yeah.
Then I feel like I think that's what we did last time. So, and that's probably pretty labor or somewhat labor intensive to do, but yeah.
Yeah, and again, that's what we're working on with these. And then we'll kind of incorporate more of where that brands that have generic components, making that a little more easier to crosswalk. And then I believe it, oh, sorry, John, before I jump into the next thing, I just wanted to give you a moment.
Yeah, I was just gonna say I support removing the columns. I don't see them now, but it's R, S, T, the ones that were duplicative, so.
Yeah, this is last year's list. I didn't want to put them into the other year of the list, that's why. And that's basically my main question. I guess the other main question, we don't have to finesse it right now. Is there any particular column row like view that the board wants the columns to be in any specific order? You don't have to answer that right now. It might be better just to go online after this is reposted and just kind of play or look at the columns and then let staff know what the particular order may be best suited. But we will set this up kind of, where it goes cost, the impacts and the orphans, any therapeutic alternatives. So again, we don't need to have the discussion now, but if you could just think about once this is updated and posted, the column order. And that's basically all I have regarding the setup of the preliminary list. Chris, I see your hand up.
Yeah, while you're right here, can you just touch on my previous question before we got to this about the patent exclusivity? So now you have a column that has date within 18 months and year within 18 months. So can you explain to me, if we get rid of the date within 18 months, what the year would be, I guess?
So, okay, so approved. And Heather, I might ask you to come on so you can or pay for these columns. Since they're the
all of it makes sense to me,
Yeah.
Courtney. The only question I have is, I thought you were proposing on the slides to get rid of AS and
No.
only have AT, but patent expirations have a date, and like the year, it could be within anywhere in the 12 months. So I was just wondering why the change to year from date.
So I think that the date is more specific. The year is what we're putting into the what we put into the material packets, but we can remove this column and just go off of the whole date.
I don't know if that makes sense to the group, but like, yeah, I mean, to me, it would help to know, is the date of the patent exclusivity within 18 months? Like the year is a lot more, yeah.
Challenging. Gotcha. All right, so we can just X that out then and just do the whole date. All right. Does that work for you? Oh,
That's great for me, but I
okay.
don't know, Dr. Hartung, you're going to talk next, so maybe you can.
Yeah, no, I think that's fine. Yeah.
Okay.
My question for the board is also, and for the analysts, is do we exclude drugs that we've reviewed in the last cycle or have reviewed?
No.
Do we want to?
That is a great question. I did put up if it was on the last preliminary list or on the subset list or not on any list, if it's a new drug being reported. So again, when we look at the drill down, we really start into reviewing these are the decisions that the board can make, in January. Again, this is just the draft preliminary list setup to make sure that we're capturing meaningful information. We have that. You can drill it out. If the board doesn't want to review the drugs again, we can just drill out subset list drugs. If that works. All right. Any other comments, feedback, suggestions before I hand it back to Chair Bailey? And then on to the next topic. All right. I guess hearing none. Thank you again, board. This is really, really helpful for us as we start getting ready for the 2026 review cycle. And I look forward to a more fruitful conversation next month on it. Chair Bailey, back to you.
Absolutely. Thank you, Courtney. Now the board will continue its 2025 drug review. Drug reviews are conducted according to ORS 646A.694 and OAR 925-200-0020. The board reviewed 23 prescription drugs and insulin products in July, August, September, and October, with continued discussions in November. Reports for each drug under the review are posted on the PDAB website, and links are included in today's agenda materials. Courtney will lead us off in the discussion related to the 2025 affordability reviews. So Courtney, you once again have the floor.
Thank you, Chair Bailey and board members. And we've been having this discussion for 5 or so months now. I did not really shore up a whole lot of talking points or conversation, because really I need to lean back into the board members on your review of the drugs over the last, since our last meeting. It was the intention that board members would be bringing forth drugs for recommendation to kind of have more meaningful discussion around. So I actually want to just ask the board if somebody wants to start the conversation of topics that they would like to, or any drug particulars that they want to bring forward. Chair Bailey, I see your hand up.
Courtney, thank you. I wanted to lean into one piece of that. So it was my recollection from our previous meeting that I think the task at hand for board members was to re-review all the affordability packets and come to today's meeting, potentially, maybe this is the most efficient way, potentially discussing medications that may want to be deprioritized or removed from the list before we vote in January. I believe the intention is for the January vote to truly be a vote of the list of drugs that we together have agreed on today. Courtney, is that in alignment with what our task at hand was for today?
Yeah, and let me share my screen for a second, because there is this, I just want to do a level setting. I apologize. I forgot that I had this slide deck. Because
I know, at least personally, my focus had been on drugs that I personally would deprioritize, knowing that, at least based on my understanding of our last meeting, although I am prepared to talk about all the drugs, but I thought that could be an efficient way to use today's meeting, or we go through each drug and just start at the top.
And we can get to that. I do think that that's probably a direction forward. Just to level set again, I'm trying to get into the habit of showing kind of our roadmap and our timeline so that everybody is on the same page. Again, this is our current meeting. We're having the drug discussion, and we just approved the final reports, and we did have the preliminary discussion. The next board meeting will be the vote of these drugs. So we're at the point where the board really probably won't have very much discussion about these drugs in January. It will probably come down to just the vote of your interpretation of the drugs. You know, there's been a rubric that was created to help kind of as a guidance tool for board members to look at some of the primary statutory requirements that the board needs to meet during these reviews. And then the board also will need to start thinking about the recommendations that they want to apply into the report that will accompany these drug reviews. So not only do you need to think about the drug and its vote, but if a drug is voted on as being identified to have an impact, is there any recommendations that can be sent to the legislators on maybe addressing those cost impacts? So have primarily January, some into February of those discussions, and then that final report would be submitted after the March meeting. And then again, the continuation of the setting up the next preliminary list. the hope is to have a subset list by March, so then we can get those drugs over to the carriers for the data call information, so we could get those back and do the analysis and set up for the next review cycle of the material packets and discussions. With this year, or starting in January, the board does not have to select as many drugs because you have up to 9 drugs to select under a new statute. So hopefully we'll be able to get through some of the review materials without as much without as many challenges as we've had over the last few months. Also, as Sarah had mentioned, we're going to do an outreach event across Oregon about the drugs that are selected on the subset list, and we will provide more information to you on that as that starts gearing up. Again, this was just a heat map that was created real quick for each of the drugs. This was sent out to the board members shortly after the last month's conversation, just to kind of highlight where each of those domains fell in the material packets within the scoring rubric. But these are the drugs that are under review, and I think I'm going to lean into the board members. If there's any drug that you want to look at specifically, any packet you want me to open, and I see Chair Bailey, your hand was up first. But
yeah, I did just want to see one thing, Courtney. So it feels, so we have 2 hours and 15 minutes for the remaining portion of today's meeting. I really did feel that we were tasked with last month of ensuring that we came to today's meeting really able to talk about all the drugs. Does it make sense to just start at the top, at least of the heat map you have, and go drug by drug, knowing we have a 2 hour and 15-minute window to do it? Is that one approach, or do board members have other approaches?
I believe in Dan Hartung and John Murray had their hands up, so we'll get to them and then maybe answer that question.
Yeah. So yeah, I think it's helpful to step back and think about the process and what looks like we need to vote on the drugs, but at next meeting. So is there any discussion point? Do we have a discussion time for next meeting as well, or is it just a vote and we're on to the next stuff?
It would be pretty limited.
Okay.
Probably no more than like an hour or so, because we really have a lot of other things we need to start setting up to talk about the 2026 and then the beginning of the year review stuff.
Yeah. Yeah. So, I'm happy to go through. I spent a fair amount of time going through every packet, all the packets, and identifying, in my opinion, which ones were affordability issues. And I'm happy to go through every one of those things. And, I don't know if we ultimately we need to get a list that we need to vote on. So I don't know if we go through every drug and then we vote to put it on the preliminary list for the final vote or to be considered, or what the process is. Or I kind of approached it as in the alternative frame that you proposed, Shelley, in terms of identifying the drugs that I think are the challenges versus the ones that we need to deprioritize. But so I have a handful of drugs here that I think are worth considering, but I'm up to whatever the efficient process is to get to this votable list. I'm want to pursue that.
I also took the similar approach where we only have to do up to 9 plus 1 insulin. I approached it from which ones I thought were an affordability challenge, and I have a handful as well. I don't have 9. For example, right off the bat, if they're, and I stumbled on excluded from MFP. If they're not excluded from MFP, then any MFP drugs, their costs will go down in the next 13 months at the most. We have quite a few of them that are going to be more affordable here very, very shortly. at least for some people. And so I did exclude from consideration initially any drugs that were excluded from MFP. So if there were a no, I didn't include them right off the bat. And then I went from MFP to system and payer cost and enrollee burden. That was my next one, my next priority concern. And so, yeah, I've got Emgality, Ubrelvy, Cosentyx, Creon, and Trulicity. Those are the ones that I would like to put forward, and I'm ready to start talking about them. The other ones, I don't know, we can spend a lot of time, I suppose. But I would prefer to have people go through and say, which ones do you think are an affordability challenge based on your criteria and what you have?
Yes. So John, can you give me those names again of your drugs? I'm sorry, I'm going through. And you're on mute again. Sorry, you're on mute.
That's all right. Emgality, Ubrelvy, Cosentyx, Creon, and Trulicity.
Perfect, thank you. Dr. Hartung, you said that you had some drugs as well. Would you mind sharing those?
Yeah, and I think what some of the points that John brought up are really important in terms of like affordable to whom, and so I really focused on the commercial side and reviewing the affordability for the most part, because that's kind of like will potentially have the state has the most authority to like do something about versus Medicaid and Medicare are kind of their own federal programs doing their own thing. From a Medicare negotiation standpoint, I looked at, yes, was it on the list? And I looked at the discounts that they negotiated down to as kind of like contextual about current rebates and things like that. So not necessarily like yes or no with it, just like more for contextual information. So I identified 3 drugs that are potential affordability concerns from the list. The number one drug that I flagged was Cosentyx for a few reasons. The primary driver was the out-of-pocket costs per claim and per annual out-of-pocket cost per claim on the commercial side was reported as $317. And so I kind of framed out-of-pocket costs relative to like, Medicare now caps out-of-pocket costs in 2020, I think 2026 or as $2,100 a month, which works out to like, think about $175 per, or $2,100 per year, which is about $175 per month. So I kind of had this figure of like $150 to $175 a month, that if a out-of-pocket cost per claim exceeded that, then that to me raised the burden for patients, given that the federal government thinks that at least Medicare enrollees shouldn't be paying more than $2,100 a month out of pocket for drugs. And there's some other literature that suggests that about $150 people start abandoning their prescriptions at the pharmacy. Cosentyx also has pretty rapid escalation in WAC over the last 3 years. 9% over the last 2 years reported, and then 7% in the year prior. So pretty aggressive list price escalation. Rebates, 43% rebate, but only on 55% of claims, which suggests it's kind of moderate. And then 100% of insurers reported having prior authorizations, which is not a surprise. But so for those reasons, it kind of like rose to the top as the drug on this list that presents the highest affordability challenge. And it's heavily used on the commercial side. So that's the rationale for it rising to the list for me. The number 2 drug for me in terms of affordability challenge was Vraylar. For similar reasons. In the commercial side, out-of-pocket cost per claim was $282. There are, Vraylar is a new class of antipsychotics for, schizophrenia, bipolar. There are a variety of pretty low-cost antipsychotics. Granted, this drug may have some innovative benefits relative to those, but still it's, many low-cost options, alternatives. The price escalation has been modest in the 5%, which is typical. Price concessions, 10%. So really not a lot of rebates going on. This is most heavily used in the Medicaid side, but there's still some commercial exposure. Yeah, so those are the reasons why. And I also look at stakeholder input. I didn't mention that for Cosentyx. So there was some modest stakeholder patient input that's suggesting some issues. So going back to Vraylar, pretty minimal, but in terms of stakeholder. But so those are the reasons why I include Vraylar as an issue. And then the third drug that I selected is kind of I'm kind of not totally convinced, but I put Nurtec, sorry, for migraine. Again, not as $168 out of pocket per claim, heavy commercial exposure, modest price increases with the WAC. Modest rebates. But stakeholder input was very significant for this drug, in my read of it. So I kind of, to me, it's potentially an affordability concern, but it wasn't not as striking as the other two that I just went through. So those are the 3 drugs that I identified.
Dr. Artem, thank you very much for spending the time and going through the analysis of each of the drugs. Hopefully it has sparked the lights of the rest of the board members to kind of provide their analysis. John, I have yours documented. Dr. Hartung, I have yours. Shelley, you said that you had gone through and since
Oh yeah, I have a list, but my list is a little longer than my peers, so I'm
okay. We're here to kind of
what I say. So I am very willing and able to share my list, but it's probably best we hear from some other board members before I share my thoughts.
Okay. Is there any other board member that would like to provide their recommended top drugs so that I can document them and then we can kind of run the analysis from there? Mr. Kennedy.
Yes, I'd be happy to. I won't be quite as eloquent as Dr. Hartung was, but I will give you my list anyway. Number 1 seemed like kind of a no-brainer. Cosentyx was my number 1. And number 2, I had Vraylar. I wasn't sure what to do about the CGRP inhibitors because there's 4 of them on the list, which tells me it may create less of an affordability issue. Let's see. I also had Creon on my list. And those were really the top 3 that I had of those 3 on my list. I have Trulicity as kind of what do I want to say, sort of marginal, I would say. But those are the 3. Yeah, I would add Trulicity on there as well. So those are my top picks.
All right, that helps me quite a bit. Thank you. Michelle, Lori, Chris, Michelle, I see your hand up.
Yeah, thank you. I had also Cosentix, Creon. Let me pull up my other sheet. Trulicity and Frailar.
All right. Thank you. I see Chris's hand go up.
Yeah, you did. I'm not sure
Okay.
what's going on with my camera. I'm sorry.
It's okay.
There we go. I agree with what Dr. Hartung, and I'm not sure if it was Shelley or Dan who said sort of filtering out the Medicare list. I think that is a good place to start, and I would agree with having those not on there. For me, I didn't make it a very long list. I went through and I appreciated the rubric, which was very helpful for me, but I really landed on Cosentix as the one that to me is an obvious sort of challenge for the system here in Oregon, and I am happy to vote on others, but I think that that's a clear one that creates an issue for the system and would be very supportive of us identifying that as a affordability challenge in the state.
And was that the only one that you felt?
Yeah, I
you
mean,
wanted?
I think
Okay.
arguments can be made for the ones that have been listed for Creon, for Vraylar, Ubrelvy. I think there's Trulicity probably I think the others have listed, but for me, the one that clearly stood out was the Cosentix.
Did you want to add any of those just as far as like an initial concern so that because I'm kind of tallying where board members' perspectives are on any of the drugs, not just one specific one. But if you're the primarily
So
focused
how
on
do you see it
Cosentix,
working next week, Courtney, I guess, or next month? Are we going to go through and vote on everything like this, the 16 or so that are on the list, or are we just going to vote on a subset of that subset, I guess?
yeah, I think more of the subset because I mean I'm looking at what the other board members have said, and we're looking at some like no real conversation on Ajoby or Entresto, Xarelto, are those even worth bringing over for a vote? Or we can pull all of them over and then we vote each one of them, kind of like what we did with our recommendations. It really is up to the board's discretion. But I just want to make sure I'm capturing the any board member who has a concern of any of the drugs that have been discussed over the last few months. This is, kind of making doing a tally of what perspectives are.
I would be fine with voting on a subset list of any of the drugs that have been mentioned so far. Courtney, I don't know what the rest of the group feels instead of having, 16 votes or whatever.
Yeah, it'd be 27 because you have to also do the insulin products.
Yeah, we're not talking about the insulins at this time, so yeah.
Not at this time, but it doesn't, yeah. So with that, did you have additional drugs that you wanted
No,
to add?
I think
Okay.
for me, Cosentix is the one that I felt like had the obvious challenge.
Okay, thank you. Lori, before I get to you, I want to go back to Michelle because she had highlighted hers already. So
yeah, I was just responding, Courtney, to your question about whether we want to remove drugs. And what I would recommend is to remove drugs that currently have generic competition and drugs that are subject to the MFP.
So I don't have a list of any of the drugs that currently have market competition. That's additional analysis that we don't have time to run right now. So I don't know how meaningful that would be if they're the MFP ones. Then we could possibly, we can pull those out, but it would need to be a census across the board.
There's generics for Entresto and Xarelto.
Okay. Let's see if we can get some other board members. Lori, is your intention just to give me your numbers? If so, do you mind holding on for just a second so I get to Dr. Hartung and then I can do the tally? All right, thank you. Dr. Hartung, I see your hand up.
Oh, in terms of the MF, I mean, I mean, what do you mean by exclude, like not nominate? So I guess the process I see is like if board members want to advance a drug for that we vote on, you know, like we've all mentioned some that are for sure affordability challenges, some that may be more or less of a concern, but still kind of rose. You know, I think that all those drugs, we just put them up and then we just vote on them, you know. And then in terms of like, so if individual board members feel like if they entered the Medicare negotiation process that they don't want to consider because of that, I think the generic thing is important and I think that, you know, awareness about that is critical. I think that came up at some point that we have, we know which ones have generics available, that are on the market. And if that's true, then like that would be a reason that it's probably not an affordability issue anymore, and then that wouldn't be nominated or voted on. For me, my personal opinion is that the Medicare negotiation piece is, again, I'm focusing on a more of a commercial angle here, and that like there still may be issues on the commercial side. I think the original Medicare negotiation piece, when the legislation intended it to be implemented across commercial plans or parts of it. So then that never was fulfilled. But so for that reason, I think that it's a contextual piece, but not an automatic exclusion.
Michelle, has your hand up to comment back to Dr. Hartung? Yeah.
Yeah, what we are seeing with the MFP drugs is erosion of the WAC prices across the board. So that would impact commercial Medicaid as well.
All right. Well, why other board members think about process of how they want to do it. Lori, Shelley, can I grab Lori real quick and then come back to you? Okay.
Yes.
Thanks for your patience, Lori. If you're ready to give me your names, I will document them.
Well, I had Cosentix as well. And I was also struck by barriers and how they impact people's ability to actually get a drug. So I put Ubrelvy on my list because it, especially with the equity lens, seemed very unaffordable looking at barriers. I have Trulicity, I mentioned, and Creon as well.
Okay, thank you very much. And Shelley, do you want John to go first, or do you want to take it?
Please let Mr. Murray go, and then I'll share a lens approach I was taking.
Okay.
I guess I would just comment on the process. I think that each of us are expressing our concerns for the different drugs, and we have different lenses and different experiences and different priorities. But in the end, I think we should just put each drug up and vote on each one, whether we think it's an affordability challenge or not. Our preferences will show at that time, my opinion.
Thank you, John. Chair Bailey, you ready?
I acknowledge and hear what you're saying related to that, John. I'm not opposed to that. I just came to this meeting thinking we were deprioritizing some, but either way, it'll come to the same answer, in my opinion. I can see a couple things. Obviously, Michelle, thank you for reminding all of us related to the drugs that now in 2025 have generics, as well as the ROC reduction that we know is hitting now and will hit in 2026. One challenge related to those two elements, as well as the MFP, is I personally, I'm very conflicted trying to look at 2023 data and vote for 2023 versus moving forward. So I can go the will of the board related to that, but that's why my list ended up being laughably longer than my peers, because I did not exclude MFP and I did not exclude drugs with a reduced WAC or drugs that we will believe will likely have a reduced WAC. So with that said, my list is a little bit longer than my colleagues, but I also appreciate and understand exactly why my peers came to the list they came to, and why maybe we just vote on all of them in the next meeting. But I'm happy to give you my list, Courtney, if you would like that.
I
So
appreciate it.
so Vraylar, this is not in any particular order.
Okay.
But Vraylar, Costenix, Creon, Trulicity, Ozempic, Mounjaro, Entresto, Xarelto,
Hold on a second. I got Manjaro. Or is it after
Entresto, Xarelto, Eliquis, and Jardiance, keeping in mind the caveats that I shared earlier. So I'm not wedded to that list. That was just me personally working on it from the lens I was evaluating it from.
You said Trulicity?
I did say Trulicity, yes.
I think I missed some because I have said Violet, no to Entresto, no to Ajovi, no to Imgalzi.
I just focused on what I said yes to while my colleagues have been talking. But I hear what Mr. Murray is also saying, that his perspective related to the vote in January very well may have been, while we're having discussion now, it sounds like his thought process was that in January we would still vote on all of them, and perhaps the votes would somehow be similar to if we had completely avoided the drugs altogether for the final vote. I'm open to whatever is the will of the board.
What I've heard and tracked so far is all of them be pulled over for a vote for next month, just independently. But there are definitely Cosentyx every single board member has mentioned. And followed closely by Creon. And there's a couple that have like Vraylar and Trulicity have the same numbering. And so that's why I was trying to ask Chair Bailey, just as far as like the numeric ordering from what others, since yours was longer.
I didn't number mine.
No, I don't need you to number them. I just want to make sure I capture them correctly. So if you're looking at like the oops, I lost my mouse. So I don't, all I have for the first group is this Vraylar. Did you have other ones that were in that first group?
I had Entresto on my list from that first group.
Perfect. And then I have Trilogy, Xarelto, Cosentyx, and Creon.
Oh, Trulicity is the drug I had intended on.
Trulicity. Okay. Not Trilogy. Okay.
Trulicity, Eliquis, Xarelto, Costenix, and Creon are on my list. And then from the next one, again, I viewed the assignment differently, obviously, but so I apologize for going through it this way. But Jardiance, Mounjaro, Ozempic, and Trulicity. So Trulicity, not Trilogy.
Yep, gotcha. All right, so I have all of yours tallied up.
But obviously what I just shared was more comprehensive. So I'm not looking to, if board members narrowed it down to a smaller subset, I don't want my lens that I approached it from to result in going a different path than what my colleagues were also considering.
No, because I don't think it was more elaborate or less elaborate, Dr. Chair Bailey, because kind of what I've been tracking and what I see is, even though all these were pulled over, nobody mentioned Ajovi. No mention of Eliquis or Xarelto or Ribelsis. So those are the, 4 drugs that we know probably won't pull over, but the board does have the opportunity to.
I believe I
reevaluate.
referenced, no, never mind. Sorry.
Okay. So there will be some that will just be no votes or not as, they're not as, from what I'm understanding, is maybe not as high as a concern compared to the higher mention of Cosentyx.
I do think though, one helpful discussion we might have, because obviously I didn't filter it some of the ways everyone else did, is like having just that discussion about, as a board, before we vote next month, do we want to exclude MFP drugs? Or to Michelle's point, do we want to exclude things that we know are generic in 2025 that weren't generic in 2023? I'm open to all those discussions so that when we vote, is our perspective, we're kind of coming into the vote. Like, are those discussions that would be helpful to have? Does anyone have, because obviously it seems to me that many people did exclude, and so if that was one criteria that the majority did, that would change obviously when I vote in January. But Mr. Murray, your hand is raised.
To your question, Chair Bailey, I guess I would again just say, I think we should just go down each list of the drugs and vote whether we personally believe in our list that it's unaffordable. And all this will shake out. There'll be a confluence of opinions, whether we believe MFP drugs are really going to reduce WAC for commercial plans. For all of them, I can't say. I would hope so.
Oh, I believe they will. I'm not,
I
I don't disagree with the sentiments of my colleagues. I was just looking at 2023.
Oh, yeah, sure. No, I understand. I understand all those things. I think that we each bring a different lens to it in some respects. Not to say that one's more valuable than another. Like, I can't say that and impose on the rest of the board members that the MFP drugs be excluded. I think that just our vote really would be the better way to do it, I think.
Yeah, I'm happy to pull them all over, then everybody has their, without adding additional criteria. But I think that the conversation just kind of level sets where the main concerns are. And hopefully preparation, just in the sense of, again, board members, please consider, if we know that you have drugs such as Cosentyx and Creon that are looking to be considered a impact to the system or patient out-of-pocket cost, are there any recommendations that would help that we could apply into the report that might, help some of these cost concerns? Laura, I see your hand up.
So I was looking at the PDAB in Maryland and Colorado, a little bit about their processes, and the thinking of, we are making a recommendation, not actually a decision, and thinking about the success of actually moving something in that direction. I tended to look at it more from the perspective of which drug is going to rise to the surface the strongest, like Cosentyx seems to be on everyone's list. My worry is if we do too much of a deliberative process, that we're going to run out of time, and we have a lot of other activities to discuss and figure out in these 4 hours once a month.
Yeah, that's why we're having this conversation. We've kind of level set with the concerns are, we'll pull them over. Most board members know what they'll be voting on. Like I say, we probably won't accommodate more than an hour at next month's board meeting for this topic, because we do need to start diving into the 2026 preliminary list and start getting that shored up. So again, so I'm asking board members, you know, when you come to do your vote for next month, it's, you know, what you're gonna have. And then again, any concepts or suggestions that might be applied into the final report for the drugs that are identified to maybe see what may help eliminate some of these concerns. Dr. Hartung, I see your hand up.
Yeah, I mean, I think in terms of voting, we don't need to vote on every drug. We just need to vote on the drugs that have been discussed within the, you know, right now as being potential. And I think it's helpful to, you know, I have a rationale for the ones that I advanced, and some of the, but I'd like to be convinced of these other ones. So if people feel strongly about something that wasn't on my list and I've heard some things like, oh, MFP, like maybe we don't need to worry about it. That's a perspective, as to John's point. So, you know, I think if people feel strongly on drug, it's important to voice the reasons why. Like, you know, I selected on the migraines, I selected Nurtec, and then other people have selected Ubrelvy. And so I want to know, you know, let's hash out why one and not the other. And like, I convinced myself internally why one has an affordability issue, but I'm also open to being convinced and discussed another opinion as well. So that would be helpful for me to hear more like rationale for, and I know some people have provided that, but some haven't. So.
And Dr. Hartung, I think that's a great segue. I do want to be mindful of a quick break that we probably take, but for the next hour and a half, I think that we have the list, we kind of everybody's kind of points. This is where we can start diving into maybe more rationales of some of these drugs that were mentioned, because as I've mentioned, Ajovy, Eliquis, and Ribulsis were not mentioned at all. So we may not be worth the time to even pull them over, you know, consistently. But some of the other ones that maybe have like one vote on it, you know, such as you said, Ubrelvy or Emgality. Is there any other identifiers so other board members may have the perspective that the person who voted on it may not have had? So before we jump into that, Chair Bailey, do you want to take a quick break? It's a little bit early.
Yeah, but I do want to acknowledge that Mr. Murray has his hand raised. So yeah, I would like to hear from Mr. Murray.
Okay.
I was just going to mention that one of my main filters here was whether a medication that's on this list has any other mechanism of possibly becoming more affordable. So, and that's the way I viewed the MFP list. Are there mechanisms in place that might lower the price to enrollees and system and plan payers? So, for example, Emgality is not on the MFP list. And I'll just run through it really quickly and then I'll be done. But utilization is high. Great. It's an effective drug. Price evaluation is high. Cost is going up more than inflation. Price concessions are low, but enrollee burden is high and system and payer costs is low. How do you achieve low system and payer costs when price concessions are low? Is it just being passed on to the enrollee? And if it is, that's why it flagged on my list, for example. And it's been out for 8 years. It's beyond, I think, isn't it, beyond patent expiration. So that's just one of my rationales as an example. So thank you.
All right, well, Mr. Murray, thank you for sharing that information. It looks like it's 10:25 a.m., so we will go ahead and take a 5-minute break and resume approximately 10:31. 10:30 timeframe Pacific. Thank you. Okay, welcome back, everyone. Melissa, could you do a quick roll call just to confirm we have board members present before we advance the discussion?
Mr. Chair, Shelley Bailey,
Present.
Vice Chair Dan Hartung, we'll come back to Dan. Lori Hoagland,
Present.
Dan Kennedy,
Present.
Michelle Coder,
Present.
Chris Lehman,
Present.
John Murray,
Present.
and Vice Chair Dan Hartung. We do have a quorum, Chair Bailey.
Okay, let's go ahead and continue our discussion.
All right, thank you, Chair Bailey. I will share my screen where we left off. Again, with the intention for a discussion to kind of look at justification of selection of board members, drugs that were identified. So for Vraylar, Dr. Hartung, Shelley, Dan Kennedy, and Michelle all selected that as a drug of consideration. Dan provided a justification, or Dr. Hartung provided a justification. Shelley, I see your hand up.
I'm happy to provide additional justifications if it is helpful for our dialogue, or is that what you're looking for? Additional, or are you hoping more for those that don't agree to provide feedback?
What was your rationale for selecting that? Like Dr. Hartung provided a pretty strong rationale why.
And we'll just pass on mine because very much is in alignment. So I'll make it efficient then.
Dan Kennedy, you had selected Vraylar. Do you have any additional comments of why?
I am in alignment with other board members.
Okay, and Michelle, same question to you.
I have nothing further to add.
All right. So Dr. Hartung, I know you're kind of late coming in. My question was, we're going to go down the list and have board members that identified a drug on the list to provide kind of the rationales, such as the same of what you had provided. We just started with Vraylar since we already heard yours. Shelley, Dan, and Michelle felt similar to your rationale. So that catches you up. And Chair Bailey.
Thank you. During our break, I went back and cross-referenced my list. So hearing my peers, and because most people's lens did remove drugs that will have a 2025 or 2026 MFP, or sorry, 26, 27. May I adjust my list? Because I would like to take 4 drugs off my suggestion, and because these were drugs that I was the only individual that added them to the list.
That's fine.
So the ones that I would like to remove would be Entresto, Xarelto, Eliquis, and Jardiance. And so that would lead me with providing 5 drugs that I thought may present affordability challenges. And I think the only drug that my peers did not lean into as much that I had on my list was Mounjaro.
And did you say you wanted to remove Ozempic?
Yes, sorry. I did not say it, but somehow you read my mind because you're aware that it is on the MFP list.
Okay. So now I have 5 drugs for you, which is Vraylar, Cosentyx, Creon, Mounjaro, and Trulicity.
That is accurate. Thank you for allowing me to make that modification.
Yes, of course. All right, well then, let me do some highlighting here. No board members had an indication for Entresto or Ajovi. So we will go to Emgalti. I have John. You indicated that Emgalti is a drug of consideration. Can you provide some background of your rationale?
Yes, where utilization is high, as I mentioned before our break, utilization is high, which is great if it's effective. But the price evaluation, where if it's exceeding inflation, that's a concern to me. Price concessions are low. So the price is going up more than inflation. Price concessions are low to the system and payers. But mostly what caught my eye was the enrollee burden is high and system and payer costs are low. And I didn't understand why that was. If we're going to consider patient out-of-pocket costs, that was a huge flag for me. I don't understand why it worked its way through there like that. But if the end result is that the enrollee burden is high and equity impact is yes, then that's one I would choose.
All right. Thank you, John. So going on to the next one is Nortec, which Dr. Hartung identified as a concern, and he provided his rationale already. The next drug is Embrevi, and again, that's John and Lori. So that's John, going back to you.
Okay, again, I approached it from the rationale that there are no other market influences to possibly control the high cost of this medication. Utilization is high, price evaluation is severe. So even more so than Emgalti, Ubrelvy is severe. Price concessions are moderate, enrollee burden is moderate, system and payer costs moderate. It was approved in 2019. It's been on the market for a while. Why isn't it more affordable? I think it has some negative affordability issues in my mind.
Okay. Lori, let's go to you now.
So there's cost involved with anytime you have a high percentage of prior authorization, and it's only 4 out of the 11 340B pharmacies carried it. So the access for folks that are poor or maybe marginalized, which actually they mentioned for all of the migraine products. So I felt those were also important to consider in addition to the things that John's already brought up.
All right. Any other feedback from board members on their rationale or change in their determination? Okay, thank you. Moving on, we have now Trilogy, and Lori, you were the only one that identified that one.
It was not Trilogy. I'm sorry, it was Trulicity.
Okay, let me change. All right. So none for Eliquis, none for Xarelto. Everyone agreed for Cosentyx. Does anybody want to provide rationale for their vote of Cosentyx, or is it pretty much unanimous across the Dr. Hartung's rationale is kind of the gist of the impact? Seeing some heads nod, I will go with.
Yeah, Courtney, this is Dan.
Yeah.
I would just say that for me, Cosentyx came out negatively in pretty much every single category. And it was kind of an outlier as being the least affordable of the group.
Okay. Sounds good. So we're moving on to Creon. We had John, Shelley, Dan Kennedy, Michelle, and Lori. I guess starting with John, your rationale for Creon.
I have a problem with the drug that was approved in 2009 being on our unaffordability list. And this is where, as I said earlier, I will apologize for my bluntness, but I don't understand why a drug like this cannot be available generically. And I know the formulations are different for the generics and they're out there, but it's still high utilization. And so that means that it's effective for many patients. Why is the price evaluation going up severely? Price concessions are severe, which means there aren't any, in my opinion, or at least I think that's the way it reads. System and payer costs are high and enrollee burden is moderate for a drug that's been out for many years. Is it because games are being played with the formulation and they just apply for a new patent? What is it? Why is it such that it's unaffordable like that? And it's excluded from the MFP list, but it's still high utilization. So.
Thank you, John. Moving on to.
I would just like to add some additional points to support what Mr. Murray shared.
Mhm.
I do feel the gross to net on rebates, or what we estimate to be the gross to net, is not as robust as it is with many other drugs. The patient out of pocket annual is, although looking at the matrix and how that's scored, like the dollar amount is over $1,200 a month, or excuse me, $1,200 per year. And so because in large part for me, the less likely to be rebated as well as the higher patient out of pocket.
All right, thank you. I appreciate the additional clarification for your rationale. Dan Kennedy, or sorry, I see Michelle's hand up, so we'll go with Michelle and then followed by Dan rationale.
I would just add the 6% year-over-year increase.
All right. Dan Kennedy, did you have anything to add for?
Oh, yeah, I'm just pretty much with John on this, that I don't understand why the price has been maintained so high and it keeps going up and up. It's a very necessary drug, but I also understand that there are a number of different formulations. So that lends also to my misunderstanding why the price remains so high.
And Lori, you're the last on the list.
I don't have much more to add, except I did notice that there has been a shortage issue with this medication, and I'm not sure where that's at right now.
Let me see if I can find it. I thought we checked. Yeah, so the health and equities write-up did identify that some shortages have been determined, but it wasn't on the shortage list as of 2024 when this was, or on the current, sorry, it's not on the current shortage list. I'm sorry, Dr. Hartung, go ahead.
Just an informational note on this issue around Creon and all these pancreatic enzymes, that they're different than like one small molecule that can be manufactured and chemically synthesized and have 10 generics out when patent exclusivity is lost. And so it creates a situation where you have all these manufacturers of multiple different formulations of enzymes, and they're all like, you know, these special formulations. I wasn't sure, but I just did a quick look on the manufacturer's website. And this is one of these. There's a couple other drugs like they're manufactured from porcine, you know, enzymes, pancreas, like Acthar is another drug that like absurdly expensive. It's got a magical manufacturing process that relies on pig pancreas. It can't be replicated. So that's what leads to this situation where you have this brand product that can't be synthesized chemically, and you can't have cheap generics for it, and you have the situations like this.
Thank you, Dr. Hartime. This additional information is meaningful. Chris, I see your hands up.
Yeah, and this is just a question for the general group, because this was, I mean, I had only chosen one, but the Creon was sort of the one that I was on the fence about. And to Dan's point, because it is so specific, and I think we heard from multiple people in the public testimony about the challenges they had when switching insurance companies and things, having to start on a different, you know, sort of equivalent product, but it never worked as well for them. And they had to go through this step process to be able to get back to the Creon because it was so expensive. I focused on the enrollee burden being moderate, and I was sort of more okay with that. But does the group feel that, I mean, did you consider ramifications like how these decisions could affect access in the future when you were making decisions? Because I agree that Creon did seem to like be a challenge for the community, but it also resonated with me, that sort of public comment from the people that we heard, right, testifying to us about their worries about access based on decisions that were made about this product. And I'm sorry, I'm not maybe articulating that very well, but I think you get the gist of what I'm trying to say.
Yeah. Chair Bailey, go ahead.
Yeah, no, I mean, Chris, I certainly remember I remember the mother who provided testimony related to the challenges related to access and, you know, caring for her child when formulations changed or milligrams changed. So that was very meaningful to me. I do, from my perspective, I looked at that testimony and all testimony because I was able to participate in all the forums last year, or almost all of them. I think I missed two. But the one thing that I continue to think of in the back of my head is from my perspective, while we're shining light on drugs that may present affordability challenges, or also in our reports providing additional context as to potentially why drugs may present affordability challenges, I remind myself that because they're in Oregon, this board is not involved in setting upper payment limits or anything like that. That's just something that I continue to remind myself when I'm trying to make informed decisions, is that is not the role of the board at this time. And so if that ever was the role in the future, I would anticipate that would be an entirely different process with an entirely different lens. And so at least that's the viewpoint. I try to take all the public feedback into consideration when I'm also looking at the work we're doing.
Thanks, Chair Bailey.
Absolutely.
All right. Was there any other comments that anybody wanted to apply regarding Creon? I think I do want to be mindful of time, just so we can review some of the insulin products as well. I don't have any, perspective on insulin, and I want to make sure we're going to set up that voting process for next month as well. So just want to make sure we have enough time to do that. But before jumping over to insulin, Chair Bailey, did you want to provide any rationale for Mounjaro?
Yeah, absolutely. I mean, well, it's obviously separate feedback than the Trulicity, but I just, felt that on Mounjaro specifically, sorry, just looking at my Mounjaro notes, that the average out-of-pocket per enrollee was something that I still felt was significant. Clearly, I've heard the feedback related to alternative ways that people might receive support with copays and things, but I still felt that that was very high, even looking at that drug kind of within the therapeutic class. And I also felt there was a lot of social determinants of health burden related to prior authorizations, like 64% of the plans required a prior authorization and step therapy. And so I recognize that this is very much a medical condition that there's a lot of press and a lot of discussion and visibility on, but I didn't want to not have that discussion just because other stakeholders are also talking about these drugs. So that's why, from my perspective, that I wanted to at least, not dismiss the potential affordability challenges that that drug may present. Similar mindset related to Trulicity. So just looking at the total payer spend, the total per enrollee out-of-pocket expense. I do want to recognize on this one, it does have a more robust gross to net than some of the other medical conditions that we've looked at, but I still felt both from the PA required, in this case is even higher than on Mounjaro, that there was a very significant social determinants of health challenge. There's obviously, even on a high rebated drug, there's volume considerations that obviously still impact the system. So I just personally felt, and then obviously removing the MFP, I felt that I just didn't want to dismiss the impact that some of these drugs may have on the broader ecosystem, both to payers and to consumers.
All right, thank you, Chair Bailey.
Sorry, that was a mouthful, but.
And just for reference, John, Dan, Michelle, and Lori also identified Trulicity as a potential impact. Do anybody else have any rationale why they selected the drug outside of what Shelley has already mentioned? Okay, I guess hearing none. Yeah, Chris.
Yeah, before we go on to the insulins, was there a way that you guys made a decision about Trulicity over the other antidiabetics? Because for me, when I was looking at the migraine products or the antidiabetics, it was hard for me to say this one, but not these other two or three, or in the antidiabetics, the other four. So is there a way you can help me understand sort of what the difference was with Trulicity compared to the others and why that one was chosen? Because that was hard for me.
I'll at least throw out the way I was looking at it. I can see John raise his hand. I was focused a lot on the out-of-pocket expense per enrollee that was different than some of the other drugs in the class. Again, I had to exclude a drug, or I just excluded a drug that had MFP. And then I also looked at volume. So some of the other drugs, obviously some of that's obviously payer formulary determined, but the comparative patient out of pocket was a piece of that I looked at. It was one of the lenses. But Mr. Murray, your hand is raised.
Yeah, Chris, I would go back again to my comment about the possibility of assistance on affordability for these medications, where Trulicity isn't on the MFP list. I don't see hope for it changing in the near future. And that's what triggered it for me versus the other ones, which I think we're going to see reduced WAC in the other ones, Chris.
Thanks, John. And then on the migraine products, like the Ubrelvy decision, was there something that drove the Ubrelvy over the others?
Kind of similar thoughts as far as assistance towards affordability in the near future, but just then I focused on enrollee burden and system and payer costs. I don't mind, and for example, I don't mind high utilization if it's an effective drug and plans want to have it on their formulary. That's great. But price evaluation where it's still severe and it's increasing more than inflation, and the price concessions are moderate, That doesn't jive with me very well when it comes to affordability to the patient walking up to the counter.
Dr. Hartung.
Yeah, I mean, how I approach the migraine drugs, I mean, I looked first at out-of-pocket cost, and then I looked at kind of the overall utilization in terms of the patients impacted. And for me, like Nurtec, I selected Nurtec versus Zilbrevant. They're both kind of like similar. Nurtec is, I had to go back and I have a bunch of notes, but I had to go back and check, make sure I transcribe stuff right. And Nurtec is slightly higher used. And I also was struck by the stakeholder comments in the Nurtec file. Like there were a lot of patient comments from Nurtec versus the other one that according to my notes. And then I guess another issue is it's also dual, it has those dual indications of acute treatment versus prevention. So it's, you know, it probably underlies why it's used more frequently. So those are my rationales in terms of like, well, how one surface. And again, I tried to be targeted or, you know, I feel like the impact of our recommendations are going to be stronger if we're kind of select. You say we have 1 or 2 to 3 drugs versus like, I think it's important to recognize all these drugs could be adversely affect affordability for any particular patients, and they're all expensive. So, but we're trying to identify the ones that at least they kind of surface in this high aggregated.
No,
data.
I appreciate that thought and information, and I will go back and review those comments, Dan, because I don't remember the comments piece being impactful to me. So I'll review those. So thank you.
I think that gets like, I appreciate the heat map thing that was generated, but I also like, to me, it kind of equalizes all the categories. And to me, there's priorities for me. And so like, again, I view out-of-pocket costs as kind of one of the top ones. And then I have a kind of weighing to the other one. And so that's kind of how I approached this whole exercise.
Thank you, Dr. Hartung. John, I see your hand up.
Yeah, Chris, back to Ubrelvy versus Nurtec. I also was noticing that the patent expiration for Nurtec is less than 18 months. And so there is hope that the cost is going to go down, and it kind of fell back to one of my principles of decision-making. When is affordability going to happen that doesn't require my action as a PDAB member? And if that is going to be the case, then it's less of a concern for me.
Thank you, John. Chair Bailey.
That makes a lot of sense, Mr. Murray. No, I was just gonna lean into Dr. Hartung's comment that I think when you shared with us, Vice Chair Dr. Hartung, your perspective of how the heat map helped, or how you use the heat map, I think how you explained it, right? You still may personally rank different things differently, but I think the way you used the heat map was exactly the use case that I found that it was helpful for as well. So I appreciate you sharing your background on how you were using that. So
Okay. Any other discussions on the prescription drugs before moving over to insulin? All right, thank you everyone for your comments, your rationales, and for again taking the time to review all the drugs. I know it's been a lot over the last few months to get all this set up, but I see the light at the end of the tunnel with some of these decisions and conversations. Hopefully we can spend the next hour having just as much of a meaningful conversation regarding insulin products. So I don't know if it works to kind of go through the same process where each board member provides a kind of rationale for each insulin glargine product under review. Oops, wrong one. Or if there needs to be other discussions about how to review each of the products. So John, I see your hand up.
Yeah, I'm just going to dive right in there and give my selection for the one that I believe is, and it's based solely off of system and payer cost and enrollee burden, and that has to do with Lantus Solostar. They're all on the MFP list, so there's probably going to decrease in WAC considerably here shortly. But when system and payer costs are high for a medication that's been out for 25 years, and enrollee burden is still moderate for medication, and I understand administration in this case is administration mechanism is important, but still it's a burden to the plans and the patients.
Thank you, John. I marked that. And I just want to clarify that board members can select up more than one insulin product that they feel is relevant. The statute selects indicates at least one product. So if there's multiple products that were identified, please let me know and I can mark them so that you're having the insulin product that is going to show the most impact is going to be identified. I have Dr. Hartung on my list next. Do you want to provide a rationale or an insulin product or a couple?
Well, I didn't I didn't select an insulin product. I just because there's been so much activity in the insulin area in terms of price caps, out-of-pocket price caps. And clearly this is there's been decreases in WAC. And I feel like it's just basically like insulins were either hugely rebated and now they're basically like, well, okay, we're just going to reduce the WAC. So it's like ultimately, the discounts on WAC are just reflecting what the net prices were before. And I guess I didn't select an insulin that had an affordability challenge or a glargine product. I spent the least amount of time, honestly, I spent the least amount of time with this category. So I'd like to listen to what other board members have to say.
Yeah, and that's fine because again, it'll be brought over for, a vote for next month. We just want to, have that conversation so that each board member has the perspective of others. But Shelley,
I was just going to share while Vice Chair Dr. Hartung had 0, I had 3. So I guess we balance out there, right? And again, these were just drugs that I was looking at that I thought may present affordability challenges. Doesn't mean they do, but I had Lantus Solostar, primary for the reasons that Mr. Murray shared previously. I also felt that 2JO Max and Basaglar may also present affordability challenges. Keeping in mind, I'm probably the furthest removed clinically from everyone here on insulins. That's been my least area of expertise. But I felt that in large part, a lot of these were really driven by the patient out-of-pocket piece. So still, the 2JO Max is at $280, Lantus Solostar at $208, and the Basaglar at $101. And so when I was looking at the patient out of pocket versus the employer spend, I just felt that knowing that we have a statutory requirement to pick at least one insulin, I thought 3 might be appropriate to look at or consider.
Makes sense. Thank you. Chair Bailey. Chris, do you have an opinion on any of the insulin products?
I think Lantus Solostar was the one that stood out to me. Again, in both of the categories, I kind of focused on one. Again, to your point about the practice, Shelley, I don't notice huge concerns with like at the counter right now with patients paying for insulin. Like this is not one of the areas where I see huge copays for patients in the pharmacies. So and I think that's illustrated in the enrollee burden, like it's pretty low. Like I don't hear discussions like I do with Xarelto or some of the other things that we talked about in the previous section where patients are getting these huge copays with insulins. And I'd be interested to hear John's comments, but that's not something I'm seeing at the pharmacy counter.
Well, and thank you for leaning into that, because again, I think that is the disconnect between me looking at 2023 on some of this, but and now the current state of 2025, which to your point, a lot of our discussion today, or Mr. Murray, that what is the nearest term that the market forces have already corrected, right?
Yeah. Dan Kennedy, you are on my list for next up.
Yes, I'm on your list. Thank you, Courtney. Yeah, you know, Shelley, I think you bring up a really good point, and I think there's sort of this disconnect in my mind between what was unaffordable in 2023 and what current market conditions suggest today in 2025. So I think that presents a bit of a challenge. That having been said, I also had Lantus Solo Star was the one and only one on my list that I thought potentially could create the greatest affordability issues.
And, and to lean into that, Mr. Kennedy, I mean, clearly so far in our discussions today, we really have had, it seems like, majority have been looking at somewhat forward looking also. So that lens makes complete sense to me. To apply a similar type of lens to the insulin products.
All right. Michelle and then Lori.
Yeah, I think for me, again, I was thinking more along the terms of current market conditions and enrollee burden. If I had to choose any, I would probably choose Toujeo because of the access restrictions, the cost per claim. While it doesn't have a total system spend, I think that is reflective of utilization controls that prevent higher system spend. And we're seeing price compression for a lot of the glargine products due to competition that I think that will take care of itself over the long term. But if I had to choose any, it would be Toujeo.
And is that the Toujeo Max Soul Star?
Yes.
We have two of them there. Okay.
Yeah.
Thank you. And follow up, Lori.
So I'm going to be kind of boring here. Like Dan, I've concentrated more on the other medicines because there was price controls that were coming for insulin in 2025. It's a different, as everyone said, a different look than 2023. And as I was also wanting to kind of pull one out to have one, the Lantus Solastar was the one I picked out.
Okay. I think from what we heard, of course, Lantus Solastar seems to be the biggest hitter. Basaglar, the quick pin, and Toujeo Max Star also have potentials. I guess my question to the board, we have insulin glargine. Oh, let me move this over. Insulin glargine, Lantus, Simgly, and the Toujeo Solo Star, not the Max, but the Solo Star. As not being represented, but I'll just pull all of them over for next month. But just so you know, there is no conversations on those other ones. So actually ended up being a lighter conversation about insulin than I was anticipating. So I don't know if the board wants to go back and have any reviews of any material packets or any information in the material packets, or have the opportunity to review anything else regarding these before seeing what else we can do for the meeting time. Dr. Hartung, I see your hands up.
I just want to note that, and this is to the point about changing conditions, that Lantus, Solo Star, in the material packet, the WAC is now for 2024, $39 for a 30-day supply versus Toujeo is 190 for a 30-day supply. So, you know, if we're going to advance Lantus, I feel like that would be that would be a recommendation that would be dated, I feel, just based on that alone, unless there's something else that I'm missing.
That would seem in alignment with the conversation we've had, right, with some of the other drugs as well. I think, thank you for sharing that update related to the WAC. And I think, Courtney, to answer your, or help, I don't know, give perspective as to an answer related to the question you asked us. One thought that I have is you referenced earlier in the meeting that when we vote next month, you were hopeful that we may also have ideas for lack of a better term, corrective action or some sort of plan on how to improve affordability. I don't know, just trying to think myself, even on some of those drugs quickly, but I don't know if that's if we end up not having additional specific questions on the packets. I mean, maybe we could spend some time brainstorming. I know we may be brainstorming absent of knowledge because we haven't been researching that piece probably as much, since I don't know if that's been directly asked of us before, but possibly that could be a discussion for us to start having. I share Dr. Hartung.
You know, yeah, so we'll have this list of drugs that are potentially have affordability issues, and then what do we do? You know, since we just came off the discussion of insulins, you know, there's been some intense scrutiny of the insulin manufacturers over the last 5 years that I think has resulted in these tangible decreases in WAC and caps on out of pocket, and that's borne a lot of fruit. So, you know, I think we could think about, you know, Oregon implemented a cap on out of pocket costs for insulins. We could make similar recommendations for any other categories that we want. That would be something that we could do.
Yeah, that was one thing I had thought of when Courtney was asking that question. Sarah, we see your hand. You have the floor.
Thank you, Chair Bailey. Building on, sort of looking ahead toward next month and building on this insulin conversation that you just had about the 2025 insulin reviews, I did want to make sure we ask the question today, since we have a little more time in today's board meeting, about the preliminary list for the insulins, and both what questions any board members might have about the draft insulin 2026 preliminary list that we posted, and also what key information should we try to analyze, and is there any other additional key information we should look to include about insulins to inform that conversation? Because as we've highlighted several times today, the way we're approaching the insulin products is different from those other drugs. And you know, we're using APAC data to identify all of the insulin products that were used by Oregonians in 2024. which again is a very different approach from using the DPT data for the other drugs. So I don't have a specific question beyond that, but I wanted to make sure that people were thinking about those files too.
Yeah, so thanks for bringing that up, Sarah. I think before jumping over to the preliminary list of the insulin products, I can get to that in just a moment. I just want to make sure we're going to wrap up and have the conversation set up for next month. And as Chair Bailey kind of mentioned, again, having ideas and concepts for recommendation of those kind of top offending drugs that have been identified. Again, that being Cosentyx and Creon and Trulicity as the three primary ones. Vraylar is a close follow-up. And then the Emgality, Nurtec, and Ambrovi have the lowest board member of concerns. So please consider some concepts, ideas, or what could be done. Same with the insulin products. Lantus as the number one that was recommended as a concern, followed by the Tejero Max Solostar, and then the Vasaglar Quick Pen. So the intention for next month's board meeting will be a voting structure. All drugs and insulin products will be put up to be voted on independently, so that each board member can vote on their concepts of if the drug may be an affordability challenge to the healthcare system or patient out-of-pocket cost, or both. So any questions regarding the drugs that are under review today or next month's process for voting on them? Chair Bailey?
So my question was, I guess right after this question, was more back to your asking my peers or staff if you're aware of anything absent of the insulin copay cap. Is anyone here today aware of any sort of policy related suggestions to lower the cost to a consumer on a specific therapeutic class? Or not therapeutic class, like, I mean, down, I mean, I guess a therapeutic class that's not a manufacturer support, you know, a manufacturer copay card, or so absent of, my wheels are turning and I can't say that I have any direct knowledge or experience. I could think of some point of sale rebate things, but Vice Chair Dr. Hartson, your hand is raised and hopefully you got some ideas.
Well, yeah, you know, these are big concepts to be kind of spurling,
Yeah.
kind of spooling out at the end of this meeting. But I think just to have the list of drugs voted on in advance is a huge accomplishment. I'm pretty happy that we can do that. And in terms of like policy recommendations, you know, obviously caps on out-of-pocket costs would something that affects patients directly. I haven't thought about it as applies to other categories. You know, something came up in, you know, the other issue is access. And, you know, in comments we've heard of, you know, formulary management and changes of formulary status mid-year is sometimes, you know, it can be a challenge for patients if they have to switch during the year. I don't know how commonly that occurs. But that's another, like, you know, something, a linked concept that we might opine upon. I don't have a position right now on it, but it's just something that occurred to me.
That makes sense.
And this is a reminder, board, when the upper payment limit study was done, there was a whole bunch of kind of suggestions, not recommendations, but like concepts that are in there. Maybe take some time to review the upper payment limit report and see if there's anything that might be pulled or identified in there that might kind of fit in a nuance. Again, not setting upper payment limits, not trying to shake up the industry. We're just trying to come up with some ways to provide legislators with some footing forward of what you as the board members see in your practices and your profession, and then how we can ensure that patient access won't be impacted, patients can afford their drugs out of pocket, and that again, insurers are able to provide affordable health plans for people to get the healthcare coverage they need. So,
thank you for that reminder. I'm pulling up the report right now, Courtney,
yeah,
just to look at some of those potential see if any of them would directly apply to a certain therapeutic class or drug.
and we can continue that conversation more readily next month as well. Again, I just really want to make sure that the next take-home task board members need to do, now that you kind of have an identified of the drugs, next task is what do we do to help ensure, access, affordability, costs, lowering cost impacts to system and patient out-of-pocket costs. So any ideas you can bring next month will be greatly appreciated. I guess with that, any other?
Can we have the insulin? Maybe could we at least start the leaning into what Sarah had?
Yeah, I was going to transition over to that.
I thought you were ending our meeting, Courtney. Okay.
I just want to make sure we're finished with this topic of the 2025 drugs and insulin products before I jump over to the 2026 preliminary list for the insulin products. We're hearing none. I am going to save my document I'm taking notes on and jump over, share my screen for insulin. And again, no decisions need to really be made about selection of insulin products at this time. This is just a level set of what the insulin preliminary list looks like. I guess kind of starting at the beginning, there's a cover letter that just jumps you to each of the tabs below. We are going to be providing document history within each one. And this is the same for the preliminary list. Got a little bit ahead of myself on that. Just additional notes from Heather and how she set up the insulin data. And insulin data is from APAC, and so it's gross pricing. So when we have it down to the NDC level, which is much more granular than the other preliminary list, the regular drug list, it has some definitions to refer back to regarding kind of tabs are set up, the sources that we have utilized. The blue tabs, again, drugs, insulin products that are drilled down to the NDC number, also sorted by the non-proprietary name, therapeutic class, and the insulin subclass, which the insulin subclass was what the board members used in the last review cycle to identify glargine products. And then this is at the drug level where it's just the overall claims cost, enrollees, and amounts, spend amounts for the insulin products. And again, these are posted online on our website. We are doing some revamping, as Sarah mentioned earlier. We're going to be archiving once this review of the 2025 review cycle is done, we'll be archiving that to focus on the 2026. But for right now, it is on the website under the 2026 insulin review preliminary list. And Chair Bailey, I see your hand up.
And I see Vice Chair Dr. Harton has his hand raised at the same time. So, sir, you have the floor.
I just wanted to make a note for the board members, because we took this approach during the last cycle, and I don't remember exactly who was on the board at the time we made these decisions. But we made the deliberative decision to select one insulin product so we looked at all the insulin glargines versus looking at glargine, a specific glargine, aspart, humulin, every like conceivable different type of insulin. We thought that it might be helpful to look within a subclass with biosimilars and other competitors. And so we've gone through that process. And it wasn't meant to be set in stone. So I think thinking about how we approach it this go around will be helpful. Like, do we just want to just take a broad swath and just look at all the insulin products individually again, or just look at them all? Because I mean, it was difficult to like, there were some questions about, were there going to be differences within this large subclass? And it seemed a lot, there was so many complexities between comparing long acting, fast acting, things like that. So I just wanted to bring up that point again for discussion or for consideration.
Yeah, and again, just to think about, we're not to the point of making a decision for drill down or anything, but as the board starts reviewing the 2026, not only just the products, but the other drugs, is there a different process that is more meaningful for this next review that will help? And as Dr. Hartung was saying, is it kind of better to look at all drugs within a certain, molecule or non-proprietary names versus each one individual at the drug level?
Yeah, to lean into what Vice Chair Dr. Hartung was sharing with the board members who weren't on the board when we did our original, not the 2023, but apparently, I guess the 2022 data we did, it was very difficult to tackle. I think, at one point we were trying to choose a couple in the long acting and the short acting. We also had some experts come testify to the board related to the differences and why it's very difficult. It's not apples to apples, clearly. But yeah, that was very much a struggle, which is I think what led us to the approach that we took for 2023's data. And Courtney, to confirm, our update to our recommendation of the legislature is up to 9 drugs, but there still is a required insulin product. Is that accurate?
Yeah, so it will be up to 9 drugs with at least
one
insulin. So it could be more than one if the board felt that there is a significant impact across. So again, if you spent more time over the last month or so really reviewing the drugs and you're more comfortable with those, maybe spending, until next board meeting reviewing those insulin products to see if there's any other ones that may be a potential for a vote of an impact. I think it's hopefully kind of explanatory how these sheets are set up. Again, if you're looking at the NDC, the highlighted numbers or highlighted sections or the darker blue NDC to the proprietary name, and then anything in these columns is based off of the totals. So the blues will indicate the total between the additional information. So there's various ways to kind of look and consider. There are 80, I guess there's 109. So there's 80. Anyways, multiple. I'm gonna actually go from this one. Yeah, so there's 109 products. I take it back, 32 according to the NDC count. Oops, sorry, I'm not at the top. Yeah, so 109 insulin products were pulled from APAC at the granulated level of the NDC to decipher how we're going to look at for the next review cycle. And really want to encourage board members as you kind of look through this new data set for the preliminary list. Please don't hesitate to reach out to staff if you have like a concept or you see something that says, well, maybe this will be a better way to look at it. We really want to lean into your knowledge. We do from our perspective of understanding, but those that serve customers at the front line or have a strong insight of the supply chain and how we can review these products to make the reviews as meaningful as possible really helps staff. Any questions about the preliminary list, either the insulin products or the upcoming drug ones?
I just want to piggyback on what Courtney was saying. As you can see from this draft preliminary list for the insulins, we have been able to do some analysis with the 2024 all payer all claims database. So we identified these 109 NDCs for insulins that show a record of people using them. So please reach out, and if we get questions from you soon enough in advance of the January meeting, we can potentially even do some additional analysis with this APAC data to attempt to answer questions about the usage of these insulins. And there's a lot of information in this spreadsheet about number of patients and number of claims for these different products. So please reach out to us between now and the next meeting if there's some additional analysis or another way of cutting these data on the insulins that would be helpful, because we could potentially do quite a bit with the all payer all claims data, and we need your input to know what to do.
And John, before I go to you, just to kind of follow up with Sarah, as you're looking through this and you see that there's points that are not meaningful or will not help with decision making, please let us know so we can remove them to help narrow the sheet to be reviewed in the most meaningful way, because there's a lot of data, a lot of information in each column. And so we really want to make sure that as we set up this preliminary list for the insulins, that the decision points are highlighted as best as possible versus having to slide through and scroll through multiple data columns that may not be relevant to any decision making. So with that said, John, and then Chair Bailey.
Thank you. I was one of the ones that advocated for all of the insulin Guardian products being considered at one time, and I was interested in seeing market dynamics. The MFP, or whether it's state or federal pricing that has come into place since this data was generated, has really leveled the playing field, except for maybe the WAC price differences, and that Dr. Hartung mentioned, and that's in my thoughts right now, consider possibly influencing my vote in January. But going forward with 109 products, I'm going to have to fall back first on affordability as far as the top 25 lists. I won't want to see the ones that are in the top 25 lists, the top contenders, and then view it through, again, this modern lens. Is it still applicable? Are the conclusions we make from those top 25 lists, do they still apply today? And so that will be my take on it. So.
And just to follow up, John, the insulin product list is quite a bit different than the insulin product list, because insulin is driven from APAC specifically. We do get some information from carriers through the data call to get that net pricing. But it is a little bit different of a data setup for the insulin products, because it comes strictly from APAC versus the drugs that are collected for review of the drug. It's from the top 25. So, and really, we don't see a lot of insulin products on the carrier top 25. So the insulin reviews need to be a little bit different in how they're perceived and structured versus the initial setup of the drug list because those are driven from the carrier list. Chair Bailey.
And Courtney, that question and comment led directly to what I was gonna kind of lean into. When I was just glancing at some of the dollars related to co-insurance, pharmacy co-insurance and things, I reminded myself that with a little help from the internet that, I believe the copay cap, when we think of solutions or potential solutions, does not apply to ERISA plans, right? So people with many with high deductible plans, ERISA plans, that's why the top 25 carriers doesn't have, as much patient out of pocket, but APAC does, right? So even though we have made progress in many ways to help improve affordability on the copay level, there's still a great number of Oregonians that aren't able to benefit from that. Is my understanding of the copay cap accurate?
Are you referring to the insulin copay cap?
Yes,
Cap
yes.
that, so
Correct.
that doesn't affect the carriers. That affects insurers and
all self-funded as well.
yeah, because it's a statutory requirement. The insulin for a 30-day supply is capped at $35, and the insulin for a 90-day supply is, I believe, at $109.
Okay. Thank you for sharing that. I was just trying to crosswalk why we're seeing some of these dollars, and it was not my understanding that it applied to all payer types.
Yeah, and with the reminder that the cap didn't take effect until the beginning of this year. So we're really not going to see impacts
Good.
until probably until next review cycle.
Thank you.
Is there any other questions or feedback that the board members wanted to possibly provide about the preliminary list, or even about the drugs of the 2025 list that's going to be voted on next month, or anything else that I can share or have the opportunity to provide insight or oversight on while we're here? Otherwise, Chair Bailey, I think we can look at wrapping up everything. I just wanted to remind you to maybe check if Lauren Sant had come back on.
Courtney, thank you for giving me the floor, and I will go ahead and ask Melissa. Melissa, because Lauren Sant did sign up to provide testimony, and because of the weather event, I would like to ask you if you see her in attendance today.
She is not in attendance, Chair Bailey.
Thank you for that confirmation, and Courtney, thank you for the reminder related to that. So I would like to announce for my colleagues and everyone here today that looking at the wrong set of notes. So the next board meeting is in January. I would have to look at my calendar to identify exactly what day that is. I believe that's the 21st. So the next Oregon PDAB meeting is at 8 a.m. Pacific on January 21st. And there being at 8 a.m. So there being no further business before the board, all in favor of adjourning the meeting, please say yes.
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 Yes. Any opposed?
Yes.
Okay, please say no. All right, the meeting is adjourned. See you next month.